program. Our first session is on recent updates on the role of blood culture in diagnosis of bloodstream infection. I would like to invite our chairperson for the session, Dr. Kiran Patel, Assistant Professor, GMS Gandhinagar, Dr. Bimal Chauhan, Assistant Professor, NHL Medical College, Dr. Milan Basaria, Consultant Microbiologist, Rajkot. I request Dr. Neha Parekh Madam to proceed for her session. We welcome you, sir. I request Dr. Milan sir to introduce our esteemed speaker.
Hello, very good morning to everyone. I would like to introduce our first speaker, Dr. Neha Parakh, who is passionate about training and leading clinical interface for commercial outcome. Dr. Neha Parakh is a medical graduate with specialization in public health and exercise her expertise for more than 10 years in various public health program and pharmacovigilance. Her latest endeavor was with WHO as a National Consultant Public Health for RNTCP. And currently, she leads the medical affairs for BD Integrated Diagnostic Systems. I would like to welcome Dr. Neha Parakh.
Hello. Yeah. Very good morning, everyone. On behalf of BD, I would like to thank the organizers of Gammcon for giving us this opportunity to talk about the updates in the blood culture space, where we have an end-to-end play as BD. Thank you for this opportunity. Today I would be talking about, as the topic says, recent updates on role of blood cultures in the diagnosis of bloodstream infections. Now, a blood culture for the diagnosis of bloodstream infection, though considered as gold standard, there are a lot of, parameters that go in to make it a ideal investigation for blood cultures, for diagnosis of BSI. And hence, today what I'll be talking about is I'll talk about those best practice indicators and how does, some of our product lines kind of help you come up to match those indicators. So my presentation today will talk about blood culture and why does quality matters. Improving the blood culture quality, some of the analytical and pre-analytical steps which help improve the quality of blood culture, and leveraging informatics. How does informatics help in monitoring and helping you understand if the quality parameters for the investigation blood culture are in line with what is expected? So, as far as blood cultures are concerned, quality for that matter, not only for blood culture, but for any diagnostic investigation is very, very crucial. We need to understand the critical steps that impact the quality, result and outcomes of the investigation or the diagnostic test we are doing. Otherwise, the entire process is likely to go for a toss. So as far as, if we come to the disease state, bloodstream infection, it is known that it is a life-threatening condition. If it, ultimately, it has a propensity to ultimately culminate into sepsis, which is a dysregulated host response to infection. There is a lot of morbidity and mortality which is related to this disease state, but the ray of hope, the sunshine here is early identification and management is crucial, and it can definitely prevent lives. It improve outcomes. Appropriate antibiotic therapy is the key. Most patients receive empiric broad spectrum antibiotics, and that is the crux of the resultant antimicrobial resistance, and obviously poor outcomes in bloodstream infections as well. So potential impact of a negative blood culture in a patient with BSI or sepsis is, so even if you suspect sepsis or a BSI, a blood culture is done, but if not rightly performed and if it turns out to be falsely negative, what we are getting into is failure to identify a resistant pathogen and administer effective antimicrobial therapy to the effect, missed opportunity to reduce the drug usage or switch to a narrow spectrum antibiotics, the resultant higher risk of adverse reactions, missed opportunity to switch from IV to oral antibiotics, and premature stopping of antibiotic therapy. So these are some of the opportunities that we miss in the due course. So again, there is this lot of data in published data to this effect, which kind of reiterates this fact that what is the importance of, first of all, doing a blood culture, and then second, more important is doing it correctly. So blood cultures matter, that's why it is titled like this. So approximately 20% of the patients with BSI may need a different therapy. So this is what this evidence says, and there are 46% higher odds of mortality in those receiving inappropriate therapy. So these are quite quite starting figures. And if you look at the quantum of the problem and in a population, extrapolate this data in a population size of India, this comes out to be a sizable number. So this study, this is a Western data, but nevertheless a retrospective cohort study, which looks at the electronic health record data from US hospitals, and there were blood culture 21,000 subjects where the blood cultures were obtained. and antibiotics were received on the same day. 19% received inappropriate antibiotics based on the review of eventual IDAST, and significantly higher mortality in those patients who received inappropriate antibiotics. So that definitely there is a connection that how targeted therapy helps in impacting morbidity and mortality. Culture negative sepsis again had 70% greater odds of dying. So this is again a US data which talks about significantly higher mortality in culture negative patients. Hence again the importance of performing and reporting cultures appropriately. Now blood culture contamination, again something which is very basic as an issue. It is looked at a very basic issue, but again it has the propensity of impacting the quality of blood culture, and this is one such issue which leads to unnecessary treatment and costs. And most of the literature outlines three very basic parameters which, if looked at, something as basis as skin antisepsis, dedicated phlebotomy teams, and the order of draw. These are the three key factors which have been identified to impact contamination rate and reduce contamination rate. Hence but if you look at the impact, there is significant impact that it has on the quality of blood culture results. Now common contaminants known is cons, conibacteria, bacillus and other species. Now, clinical impact of contamination is again unnecessary IV antibiotics. 40% received inappropriate antibiotics, increased length of stay of hospital, and increased risk of adverse events. Healthcare associated infections, be it drug adverse reactions, pressure ulcers, delay in obtaining accurate diagnosis. So, something as simple as blood culture contamination can lead to all of these impacts, and definitely the financial impact which goes on. Now these figures are in US dollars, but if we study this in INR, definitely it will result, it will come to be a sizable number. And hence the potential impact of successful sepsis management or a bloodstream infection management is decrease in mortality rate. It improves the financials, improves the antibiotic stewardship, patient satisfaction, healthcare worker safety, length of stay, and definitely reduces complications. And hence why blood culture matters is because it improves the clinical laboratory performance and workflow efficiency. So so now the three crucial steps for any blood culture is pre-analytic, analytic and post-analytic. Pre-analytic is sample collection. What goes in will come out. So the quality of sample that is fed into for blood culture will definitely impact the result, and hence specimen collection, ease and quality of specimen collection is very important. Then second is obviously analytical, TAT of results is a very significant aspect of, because the patient at the other end is critical and clinician is anxious to understand what is it. So hence reduce time to detection and increased recovery. The, the more positives, significant positives that are, reported, and then workflow management, how this is integrated in the overall ecosystem informatics analytics of the hospital, which critical alerts are there, analytics at the end of the month, quarter, to help the microbiologist share those results with the clinician for more judicious empiric therapy which goes for the patient. So now again reiterating the fact, what are some of the key elements that impact the successful blood culture across the three phases of testing: the number of blood culture bottles that go in, timing of collection of blood culture, the choice of media, volume, definitely an important thing, how it is collected, collection, antisepsis of the skin, which is one of the key factors which has been identified to reduce contamination if it is done correctly, special pathogen, and duration of incubation. Now coming to so the first part was on how does quality impact and what are the parameters that are reported if the blood culture quality is not maintained. Now how can the quality be improved? Now, with BD, we have, a concept called perfect pair, which is a combination of aerobic and anaerobic lytic media. So, aerobic and anaerobic media combined as a set has been, widely recommended to as an ideal, way to collect blood culture from the patients. Though, there are a lot, there's the concept going in that anaerobic infections are rare. So but this anaerobic lytic media, and I'll come to what does it actually contain. So anaerobic lytic media has propensity to, along with obligate anaerobes, facultative anaerobes also are, significantly faster isolated in this media. So now if we compare aerobic plus and anaerobic lytic media, broth is similar. But anaerobic requirement is environment in this is pre-reduced because of pre-reduced media and dispensed with carbon dioxide and nitrogen. Antimicrobial absorption is present in aerobic plus with the help of resins, which absorb most of the commonly prescribed broad spectrum antibiotics, antifungal agents. The lytic component consists of saponin. Why this media is called as lytic is because it contains saponin, which releases engulfed organisms, nutrients, which reduces back. So this lyses the cells, which releases intracellular pathogens and also reduces the background noise of metabolism of these cells getting captured. And benefits is obviously for with aerobic it is excellent organism growth and recovery, and with anaerobic lytic is increased recovery and shorter time to detection compared to anaerobic plus and aerobic plus in some cases, example facultative anaerobes. So you will see, so there is a lot of published data which suggests that Bactec lytic anaerobic vials provide higher sensitivity, faster time to detection for anaerobic bacteria. There is data to compare different other brands anaerobic media along with lytic, and it is definitely, you can see the green figure here which highlights that the detection as well as the time to detection, the median recovery as well as time to detection is significantly higher with Bactec anaerobic lytic as compared to other brand anaerobic media. So significant difference observed in percentage of detection of isolates as well as the time to detection. Now, what are the other ways? So pre-analytical steps, as I already mentioned, is one of the important step to how the sample is collected. One of the important parameters which impacts the quality of blood culture sample. So here the entire if the entire journey is mapped, so you can see that the sample is collected, it is sent to the lab, it is incubated, put in the blood culture instrument, and then after the blood culture flags positive and IDST is done, the gram staining is done, the result is communicated positive, negative to the clinician, and then finally an IDST report is released as it is available. So there are three different kind of steps: time to incubation, time to detection, and time to report. These are the three critical timelines which kind of impact how fast the result can be communicated to the clinician. And so what are some of the parameters that impact? Now, time to, if the quality of specimen is low, obviously the pre-analytical is not adhered to, then the test has to be sensitive, specific enough to be able to, report correct results. Otherwise, again, after the entire process and the time that elapses, if the result is questionable, the process, the trust in the process and the investigation for the clinician goes for a toss. Now, as far as blood culture collection, as mentioned, basic step, but impacts contamination, which again, kind of impacts the output of the result. So ideally, collection should be done before the antibiotic administration, which is very clear from most of the guidelines. Site of blood straw, peripheral venipuncture on upper limb, avoid IV lines and lower limb. Appropriate site disinfection, chlorhexidine gluconate is recommended in greater than 2 months children and adults. Disinfect the septum of blood culture bottle. That this is again a very crucial crucial step with 70% isopropyl alcohol. This needs to be done wherever possible. Closed system of collection with safety wing set is strongly encouraged. Order of draw is blood culture first, and volume. So again, sufficient volume, 8 to 10 ml is what is recommended. 2 to 4 sets. One set is aerobic and anaerobic in ideal situation. Adults and children, again, less than 1% of blood volume. Generally, one aerobic bottle is what is collected, looking at the volume constraints. And appropriate volume recommended is 8 to 10 ml, but depending on the type of media, appropriate volume is as per the manufacturer's recommendation. Mixed by slight inversion of the bottle, safe disposal of the phlebotomy equipment, and then timely transport and incubation. So the guidelines typically tell you that the blood culture bottle should be incubated in the instrument as soon as possible. So there should be minimal delay in the transport of the bottle collected sample from the site of collection to where the instrument lies. So this is how a closed system of collection with the help of safety wing set is recommended. So we have safety wing set. There are two varieties of safety wing set, safety SLBCS as well as Ultra Touch. So they are available, which kind of help improve the pre-analytical step of collection. Now, blood volume again is a crucial factor which impacts the sensitivity of culture. Now, adult blood culture guidelines typically mention 4 bottles, approximately 40 ml of blood, and there are a lot of guidelines which tell you that blood volume is one of the important parameters in impacting the blood culture sensitivity. So, you can see here there is a data from Cockrell 2004 and Lee 2007 which talks about how the sensitivity is impacted with the number of cultures that are collected. So one set is 65 to 75% sensitivity, 2 sets is 80 to 90% sensitivity, and 3 sets is 96 to 98% sensitivity. Now, obviously, in Indian scenario, there are all of these investigations are out of pocket, and hence, we have to ensure how best we can optimize cost along with, impacting the sensitivity of blood culture results. So now blood culture quality matrix, though this is, lot of this, but we are, having now CAP accredited laboratories and hospitals currently. So, all of these CAP, if you look at blood volume monitoring has become one of the crucial parameters that CAP instates upon, and hence, it is one parameter which needs to be monitored by the lab. So, as per the CAP blood culture quality matrix, and what do they see as record of compliances? Records and monitoring of volume at defined frequency, and records of feedback to responsible parties. Again, contamination rate has been monitored, and there are, to compliance is record of contamination rates and corrective action and feedback of the parties. Now, leveraging technology to improve, monitor and improve quality is, there are a lot of nowadays, informatics which is available. Few related to instrument. There are also, analytics which kind of hospital are developing themselves to monitor these parameters. Digitization of these, results, and collecting an analysis of cumulative indicators has become practice, and it is picking up fast. So now, for improving the pre-analytical, 3 parts which are important is optimizing the workflow. So for example, how fast is the blood culture bottle reaching the lab from the site of collection? After it is reached the lab, what is, how fast it is getting loaded in the blood culture instrument. So these are some of the workflow gaps and inefficiencies that these informatics typically try to identify, and then evaluate different interventions. If training and education has been done, or if, any other intervention has been put to place, these informatics again help you monitor the improvement month on month. So Now, a lot of times, all of these, things are manually kept, which again is time consuming and, leads to errors as well. Again, optimizing the blood collection process, we saw that there are a lot of, parameters in blood collection process which impact results. Whenever there are interventions done, first is what is the baseline of the lab, these informatics helps you capture that, and then what is the impact of the practices intervention that have been put in place. You can again monitor these, and then definitely tabulate the quality metrics, monitor them regularly, and take corrective action. Now at BD, just a snapshot of what we offer in terms of the end-to-end bloodstream infection diagnosis is concerned is starting right from collection. So we first of all, not even products, but it is also the value added services. We have a a workflow optimization service which is called bloodstream infection audits. So these are typically workflow efficiency checks, or in a very crude term, audits, which help the hospital identify where are the gaps. So there is a structured checklist that we have developed, which we run at the hospital, and the entire process is confidential. It is just between BD and the hospital or a lab, and we help hospital identify what are the current practices, what is ideal, and if there are gaps, if any, and how can those gaps be rectified. Is there a training, is there a technology, is there anything else that can be done to kind of bridge that gap? So that those are some of the workflow analysis tools that we have, which we run with the hospitals and labs. Then as far as technology or products are concerned, this is the Wingset along with the holder, which helps appropriate collection of blood culture. So this is Vacutainer Ultra Touch blood collection set. Then for growth and detection, FX40. So the small, this is the basic version, FX40, and you can scale up this version. It's a modular instrument. You can scale up this version with 3 other instrument, making it a total of FX 160. And this is the then there is FX 200 and FX 400 models for higher volume, higher throughput labs and hospitals. As far as our media range is concerned, aerobic and anaerobic lytic I already talked about. We have pediatric specific media and mycosis for isolation, detection and isolation of fungal organisms. So this is the media range that is available. Then for identification and susceptibility testing, we have tie up with Bruker, so for faster identification, and we have Phoenix M50, which is a 50 position instrument for identification and susceptibility testing. Again, like blood culture, this is a modular instrument to up to M100. So 50 can be scaled up to another 50, and as the capacity increases, and it can become 100. And then informatic solution, which is called Synapses, which enables you track these matrices, the blood culture quality indicators, and accordingly take corrective actions as needed. So Synapses is a cloud-based software. You see here, so 7 days of the week, different parameters. So this is suppose the workflow collected, received, placed in backtech, and flagging positive, and blood positive bottle removed. For each day of the week, you can, this can be monitored as to how this is playing out, and you can see if a particular day, Sunday, suppose it's a holiday and the staff is not present or is not efficiently working, this can be flagged. So accordingly you can identify which particular technician and where is the issue. Depending on this, corrective actions can be taken. So this Synapses software helps you monitor the positivity contamination rates, blood volume monitoring, as well as the culture sets, the number of culture of sets collected. So if you look at the holistic data of the hospital, say after a month or a quarter, you can identify what were the proportion of patients that were double bottle, single bottle, and accordingly share the report with the clinicians. So again, lot of published evidence to tell you that, and training and, repeated reiteration of awareness, both with the technical nursing staff as well as clinicians, helps drive this message. And there have been a lot of studies which have been done where uh, continuous training and education has demonstrated reduction in contamination rate and increased recovery and positivity of blood culture. So again, already talked about this already. So a lot of evidence to substantiate these best practices which have been talked about. So in summary, blood culture is a first critical step in process of pathogen identification and susceptibility testing. And BD blood culture broths have excellent performance, anaerobic lytic, as well as mycosis for fungal isolation. And a major factor impacting blood culture results is pre-analytic collection, and hence there are steps have to be ensured to for appropriate sample collection. Synapsis is informatics which enables fast and easy monitoring of common blood culture matrix, fulfill audit requirements, and contribute to quality improvement programs. And successful quality improvement program also requires participation of the clinical team and regular training for all the staff. Only then it is possible to achieve excellent results. So definitely it is not just the lab which can impact the quality of microbiology results. It is the collection team, lab, as well as the clinical team which can together impact. This is all from my side. Thank you so much.
Thank you so much, ma'am. Any questions?
Yeah, just want to inquire whether the Synapse software is inbuilt or we have to purchase it separately.
Ma'am, it is additional. It
Additional.
is not inbuilt. Yeah, it can be installed on request if the hospital or the lab needs it.
Okay, what would be the cost?
Cost, I'm ma'am,
Marketing,
yes,
okay.
technical
It's marketing.
person, but
Thank
we
you.
can, ma'am, will reach out to you. Rushi will get in touch with you to
Thank you.
let you know the cost.
So I request Dr. Bimal sir to conclude the session.
So, thank you, Dr. Neha. And by blood culture is the crucial play role in the treatment of sepsis. So, timely collection in proper way with all aseptic precaution, it will helpful for the patient and also reduce the mortality and morbidity. So, thank you and very informative lecture from your side. Thank you very much.
Thank you, sir. Now I request Dr. Kiran Patel sir to felicitate Neha ma'am. I invite Dr. Parekh Patel sir to felicitate our chairperson. Welcome, sir.
While our chairpersons are being felicitated, you can see a QR code on the screen. Again, I am announcing. You can the QR code was for the microbiology quiz It's an online quiz, and there will be a reward for the winner by the draw system. I request everyone to participate in the quiz. You can scan the QR code and participate in the quiz. The QR code is also available at the entry of the hall. You can scan the QR code from there as well. Thank you.
હા આરામથી બેસો ને આ ખોલીને રેડી રાખો થોડા.
बड़ा भाभी, आपको पता है आजकल हॉस्पिटल में इन्फेक्शन बहुत बढ़ गया है.
हे माँ माता जी, इसीलिए तो मैं टप्पू के पापा को बोलती हूँ कि हॉस्पिटल में नहीं जाने का, उसकी जगह पे बाजू वाली फार्मेसी है ना, उसी से एंटीबायोटिक ले लेने की.
नहीं नहीं दया भाभी, ये बहुत गलत है. इसलिए हॉस्पिटल में एंटी माइक्रोबियल स्टीवर्डशिप का प्रोग्राम चलता है.
अभी हमारे नेक्स्ट स्पीकर आएंगे ना, हमें बताएंगे इसके बारे में. Our next topic is preparation of hospital antibiogram and pathogen detected AMS audit. I would like to invite the chairperson for this session.
Dr. Kanu Patel, Professor, BJ Medical College. Dr. Gauri Shankar Shimali, Professor and Head GMERS Gandhinagar. Dr. Parekh Auditorium, Ma'am, Professor and Head Welcome.
I request Dr. Ketan Priyadarshi sir to proceed for his session. Welcome sir.
एक मिनट.
I request Dr. Gauri Shankar Shimali to introduce our esteemed speaker.
40 minutes. 15 minutes. 15 minutes.
Good morning. Dr. Ketan Priyadarshi is the author of the book Essentials of Antimicrobial Stewardship, the foundation member of Society of Antimicrobial Stewardship Practice in India, and rich involvement in research with 30 publications. He is an assistant professor at AIMS, Patna. He is qualified with MD as well as DNB in microbiology and postdoctoral fellowship in hospital infection control. Please proceed, sir.
Okay, good morning everyone. First of all, I would like to thank the organizers to bring me here on this platform. So basically, as a clinical microbiologist, we have a lots of role to play in the antimicrobial stewardship. So if we are a part of our antimicrobial stewardship team in our institute, then as a part of that team, we can do so much for antimicrobial stewardship. But other than that, other than being as an AMS team, we still have a lot to offer for the antimicrobial stewardship. So what I think of first is a very crucial part of antimicrobial stewardship, which is diagnostic stewardship. So what we understand with diagnostic stewardship is basically it is the right test by the right method and the delivery of correct or the right results in right turnaround time. So we must perform the test with the right method, the accurate method, generate a right result and report it to the clinical team in right diagnostic time period, that is turnaround time. Now, this is our main contribution towards antimicrobial stewardship, being a clinical microbiologist. But other than that, we have some other ways to contribute to the antimicrobial stewardship that we are going to discuss today. So, one but such important topic is generation of our hospital antibiogram, because this hospital antibiogram is going to play a major and crucial role in many aspects that we'll see subsequently. Another way a clinical microbiologist can contribute to the antimicrobial stewardship activity is through a innovative approach that we may be doing it, but I'll show you a different strategy or a different way to do it that we used to call as pathogen directed antimicrobial stewardship rounds. Okay, so I'll begin my talk with hospital antidiagram. So the first question asked in our mind is why we need a hospital-based antidiagram. What's the purpose of generating an antidiagram? So basically, antidiagram has many roles to play, many different aspects of play. Let's try to understand. The first role is how it is going to affect the patient's management. So basically, the initial empirical therapy that is going to be instituted for a patient should be primarily guided using these antidiagrams. It is also used, these kind of antidiagrams what we generate are used to prepare our hospital institutional antibiotic policy, so that the antibiotic policy should not be always a national antibiotic policy or an international recommendation of IDSA and ECMED or something like that. It should always be catered or cut down as per as our institutional need. So how we transform a national recommendation like ICMR or a international recommendation like IDSA and ECMED to our institute level. This cutting down of guidelines into an institutional antibiotic policy, antidiagram has a very important role to play. Even our pharmacy procurement of antimicrobials can be catered or can be directed through our antidiagram. Those antibiotics which elicit better in vitro susceptibility can be made as a part of our pharmacy armamentarium and can be introduced in the institute for treatment of various drug resistant pathogens. So this is all about role of patient management. Now the second part is AMSP, how antidiagram is going to help us out in the AMS activities. So it helps in the AMS activity to target those antibiotic and target those drug combination or infection combinations where we have to pay more focus in implementation. As well as these antidiagrams are an indirect indicator of antimicrobial resistance in our institute. So if you implement any AMS activity like you do a formulary restriction or you a prospective audit and feedback or any other AMS activity, to see how your implementation is changing the scenario, how it is progressing, how it is getting beneficial, those monitoring can also be done through your change in antidiagram. If your resistance is decreasing in your subsequent year antidiagram, it means what you are doing is going on in a correct pathway. So that is the AMS activity. The last part is how antidiagram is going to help us in our AMR. So in an institute, you can monitor your AMR trend. You can compare your institute's AMR trend with the neighboring institutes. You can compare your AMR trend with regional or national database, see how you flare up, how AMR is prevalent in your institute as compared to the national, as compared to other regions, other institutes. Those kind of comparison can only be done if you have a robust antidiagram generation. Now, if you be part of any national AMR surveillance like ICMR, NCDC, then you can contribute your data to those centers, to the national database, and so that your national database becomes robust. So, and the last but not the least, when you generate an antidiagram, you pick up in some emerging resistance. Like for example, when you generate an antidiagram for Acinetobacter, you can see a trend that the minocycline or TG cycline resistance in your institute is increasing. So you can find an emerging resistance for a particular organism like ceftriaxone resistance in salmonella. Only when you cumulate your AST reports and generate an antidiagram, you will find a trend in any increasing emerging resistance in your setup. So generating an antidiagram is not an option currently. Generating an antidiagram is a compulsory step for every microbiologist. Now, what guidelines we refer to when we talk about generation of antidiagram? Where are the rules written? So the rules are written in a document which we follow, the CLSI M39 document. The fourth edition of this document, which was readily available, came out in 2014. Recently enough, in 2022, we have an update of this document. The fifth edition has come. And but I'll recommend my audience to go through both the documents, because I personally feel that reading only the latest one doesn't solve the issue. So when you have to go through these, go through both 2014 document as well as 22 document to gather more information on antidiagram. It mentions various types of antidiagram, but the most important one is the routine antidiagram. I'll discuss each type of antidiagram subsequently. But if I have to name a few antidiagrams which are very crucial, very important, are being routine antidiagram. Then we have a stratified or enhanced antidiagram. We have a syndromic antidiagram. We have a subtraction antidiagram. We have a rolling antidiagram. And last, we have a multi-facility antidiagram. These are crucial. There are other types of antidiagrams also, but these antidiagrams are the crucial antidiagram that we must generate. Now, how an hospital-based antidiagram looks like? If you're new to an antidiagram, then how a antidiagram in general looks like? So it's a X and Y axis representation. What is represented in the Y axis in the columns is the organism name or organism group name. This constitutes the Y axis of your table. What constitutes the x-axis is the list of antibiotic. Now, this list of antibiotic can be arranged in various ways. The most two common ways to represent it, either you represent it in a class way, like keep all the beta-lactams together, cephalosporins together, carbapenems together, quinolones together. This is one way of representing the antibiotic microbial agents. The other way is to divide it into their generations. Like low narrow spectrum ones, you label it as first line antibiotics, then you have second line antibiotics, and you have third line antibiotics. For the ease of clinicians, for our understanding, the ideal is to generate the antidiagram in both the order. For what we need, we better appreciate it when it is done in the case of antimicrobial classes. You want to compare your carbapenem resistance with cephalosporins. If they are placed together, you will understand better how third generation is changing with fourth generation, how it is better than a BLBLI, how that is better than a carbapenem. But the clinicians, it won't help. Clinicians, it better helps if you give them in the lines that the first line antibiotics which my drug is susceptible. The next what I have to pick. So for the clinicians, representing an antidiagram in first line, second line, third line makes more sense. Then we also have to mention the total number of isolates you got in your institute, and against each organism antibiotic, individual susceptibility percentage represented. This is a susceptibility percentage. What is not included in them is the intermediate results and the resistant results, clubbed together called as not susceptible. So you only include susceptible percentages. What you don't include in this is intermediate and resistant results. Now, how to prepare an antidiagram? So, the first method of preparation which many of us do is we do the entry in a manual register, and from the manual register you populate the data, you transfer the data into Excels, and then use the Excel to generate your antidiagram. Some of the institutes directly do the entry into the Excel, and from that Excel they generate their antidiagram. But believe me, when I say that, when I discuss the rules subsequently, you yourself agree that Excel-based antidiagram generation has plenty of loopholes. It's a chopped up work. Somehow you are managing and doing something as an antidiagram, but always it's not a true representation of antidiagram. It's not a correct antidiagram. So how to generate a correct antidiagram? The only way to do it is using a data analysis software. Without utilizing a data analysis software, nothing can be done. And it's a very easy thing. You have free platforms available. Only thing you need is you need a person to do the entry in those platforms. Then again, in an Excel based, somebody must be sitting and doing the Excel based entry. Yeah, the same person can be utilized for entry into those data analysis software, and you can get a robust and up-to-date antidiagram. Now, what are those data analysis software I'm talking about? If you have an LIS, some of the LIS laboratory information system which hospitals are using, they have a clubbed-in antidiagram generation facility. So if your LIS is clubbed with a such a facility, you can utilize that internally. Otherwise, we have a third-party antidiagram generation tool. How CLSI defines those tools is they use the term of clinical decision support system. So to name a few, WHO has a very excellent free tool which many of will be using is WhoNet. So it needs a manual entry if you are a disk diffusion system. If you're an automated ASS system, then directly either of the systems, whatever this platform is available, all can be directly linked via software to your WhoNet, so that the data, MIC based data, can come directly to the WhoNet. It's a free software, it's a very excellent software. So the initial burden is only the entry. Once you enter it properly, then the subsequent generation of all types of antidiagram is a play, it's a finger's play. There are other third-party softwares also available, like one national multicentric study is going on, VMS study, that has a software called as IBO software. So that generates the same unit. It's a paid software, but for the VMS study participants, it made free of cost. So generating antidiagram using data analysis software minimally by WhoNet or any other software like IBOR or so is a must. You cannot skip that. There's no explanation of skipping it. Now coming to the rules of individual antidiagram, I'd like to first talk about routine antidiagram. So who can generate a routine antidiagram? The rule says that it should be a healthcare facility who can generate an antidiagram. Can a standalone lab generate its own antidiagram? The answer is no. A standalone lab which caters samples from multiple facilities cannot generate its own antidiagram, but they can generate antidiagram for their own facility. Suppose I have a standalone lab which caters definite 5 institutes, then I can generate use the data generated in my lab to generate 5 different antidiagram for each facility. But the antidiagram must be targeted to individual facility. It should not be targeted to a laboratory. Now, only verified final results must be fed into the antidiagram, and the onus of this, that all the reports what we generate is properly verified, is on the clinical microbiologist. That goes true for the patient reporting as well as feeding it to the antidiagram. So verification of all those doubtful results, inappropriate results, it's our responsibility to make sure that they are rectified first before we report it to the patient, or we report it or feed it into the antidiagram. Now, how frequent we need to prepare our antidiagram? So the minimum requirement is annual antidiagram. But if you're a large setup, you have many isolates, you can even prepare it more frequently. Like for example, you can prepare it biannually or subsequently also. One solution to this is, if you're using data analysis software, then you can also generate a real-time antidiagram. I'll say, let you know subsequently what is a real-time antidiagram. The correct word for that is rolling antidiagram. So that's a live antidiagram. On the day you clicked your platform, you generate antidiagram right from that day to previous 1 year. You need not wait for 6 months, or you need not wait for 8 months or 1 year to generate or see your fresh antidiagram. Whenever you want, you can see your last 1 year data. That is type of antidiagram is what we call a rolling antidiagram. It's the best if you have the facility to generate that. Now, there are a few parts of understanding this antidiagram. The most crucial part is how we select the isolates. The selection of isolate for generation of antidiagram is the most crucial part. So, what is the minimum number of isolate you must have to generate a good antidiagram? The answer is 30. So, a particular organism group, if you have more than 30 isolate, the antidiagram can be well prepared. Can't we prepare an isolate less than 30? The answer is you can prepare. Who is stopping you? But the reliability of that, the statistical significance of that decreases when the number of isolates fall below 30. The solution to it, you can club 2 years. Suppose I get only 20 isolates of salmonella in a year. How I'll generate my style anti-diagram? What I'll do is I'll club 2 years data. This year's data as well as last year's data. I'll have some 40 plus isolate and I'll generate 2 years anti-diagram for salmonella. Rest all isolates. I'll generate an annual anti-diagram. This is the best solution we can have. Now, how to select the isolates? So we have plenty of rules what CLSI suggests. Like we have isolate based estimate, patient based estimate, episode based, phenotype based. But I'll not try to confuse you here. What I like to suggest is, I like to suggest only 2 recommendations. What are those 2 recommendations? First is all isolate based data. All isolate based data, it is good if you want to estimate the AMR, not the therapy, but the AMR, as well as if you want to prepare an anti-diagram where for those patients who are already on antimicrobial therapy, treated multiple times, have been in hospital for a very long duration of time on multiple antibiotics. If you want to treat those patients on antimicrobial therapy, then the kind of anti-diagram you use is primarily based on all isolate data. Now, the other recommended most important is the first isolate based data. I'll tell you what are these first isolate, all isolate. But the first isolate is primarily for initial empirical therapy. A patient came to you in ICU, in ward, in OPD, how you choose the antimicrobial therapy. This first isolate data is going to give you the solution. So these are the all isolate and first isolate are the 2 crucial methods to select on the first the isolate. Now, I like to pay attention to you that first isolate is a patient-based estimate. So the denominator of analysis is individual patient. Every patient, one isolate only is accountable. All isolate is an isolate-based estimate. So all the isolate which come to you, the isolate is the metric. The isolate form the base of investigation. Okay, so let's come to first isolate. This is a little bit confusing. Try to understand it. Most of us, when we generate our anti-diagram, first isolate selection is where we do the mistake. Okay, either we do an all isolate anti-diagram generation or we try a first isolate in a wrong way. So I just like you to try and focus the attention of how a first isolate is done. And this is why if you generate a first isolate anti-diagram, by the end of this discussion, you'll realize that how erroneous the Excel-based anti-diagram generation can be. So how we define a first isolate? If we're talking about routine anti-diagram, it means first isolate of a particular organism. Specifically, that organism must be at the species level. We are not talking Escherichia, we are not talking Klebsiella, we are talking either Klebsiella pneumoniae, Klebsiella oxytoca, Klebsiella aerogenes. We are talking at the level of species. So it's first isolate of an organism at species level per patient, per antimicrobial agent, per analysis period. So it has 4 important components. First, organism at species level. Second is antimicrobial agent. Third is patient. And fourth is analysis period. Even analysis period plays a very crucial role. Okay, what it excludes all the other things like body sites, AST profile, resistant, susceptible, doesn't matter. So it's a first isolate selection. Like for example, first Klebsiella pneumoniae isolate for a particular patient A, for a particular drug like amikacin, for a particular analysis period like 2023. This is how we define a first isolate. The same thing if you analyze for a enhanced anti-diagram, which I'll subsequently discuss. One additional 5th number point added it, stratified filters. Like specimen type, location of the patient, like when I talk about enhanced anti-diagram first isolate selection, the same 4 points what I discussed already for routine anti-diagram, the 5th one added is, like for example, in blood, specific blood specimen, plus specific exudate specimen, specific urine specimen, for a specific patient care location, ICU, IPD, OPDs, for a particular department, medicine, surgery, neurology, bone transplant. So whatever these are the specific 5th number points are added to the definition of first isolate when I'm talking of enhanced antidiagram. Now, this concept, let's try to understand with a very important example. So, this is a scenario, an arbitrary scenario created where suppose a patient had many isolations of E. coli during his stay in the hospital. So, it has a particular organism like Escherichia coli isolated 5 times while in the hospital from different samples, sometimes from blood, sometimes from urine on different dates, and all have their own susceptibility in the way enlisted. Now, if I ask you, what is the first isolate for E. coli ceftriaxone for the year 2023? So, that will be this. Why this? Because in the year 2023, we have only one isolate of E. coli, that is isolate number 1 from a specimen blood, and that gives a susceptible result. So, in this scenario, the first isolate will be isolate 1 and the result entered for that. Actually, the antidiagram goes, in the antidiagram, the data goes as susceptible data. So, the first isolate selected is isolate 1 and the data goes as susceptible, that E. coli ceftriaxone is, in this scenario, is susceptible. Now, let's try to understand this. If someone asks me, give me the first isolate E. coli for ceftriaxone for the year 2024. Now, which is the first isolate? I told you 4 parameters. Analysis period is one very crucial parameter. When the analysis period changes, your first isolate is supposed to change. So, what is the first isolate in the year 2024? It is isolate 2. And for ceftriaxone, the isolate 2, the result is resistant. So, if someone asks you to prepare an antidiagram for 2024, the first isolate will be not isolate 1, isolate 2. And the resist will go as resistant. Okay. Now, let's ask a different question. Then, what is the first isolate of E. coli for ciprofloxacin in the year 2024? I told you the 4 pillars of first isolate. One of the important pillar was antibiotic. Let's try to see the data. So, E. coli in 2024 ciprofloxacin. What I can see is the first isolate visible to me is isolate 2. I go by the side and see the ciprofloxacin data. Here it's written as anti. What is anti? Anti is not tested. For some reasons the data is not available. Your disk was not available. The technician forgot to put it. So any reasons. If you use an automated system, it got terminated. So will I report anti as the data? No. The question answer is antibiotic is a very crucial part. What I'll do in this scenario, the next antibiotic for the same isolate wherever the data is available. So if ciprofloxacin 2024 data someone wants to pick me, I will pick an isolate 3 which is from urine where the susceptible results is available, and I will include this result into the antidiagram. Okay. Similar scenarios, E. coli amikacin for blood. Then I will go for the first blood isolate in 2024. Isolate 2, I will go for the amikacin result, and I saw the amica result is NP. So I will go for the next blood isolate in 2024. Sorry, by mistake it is written as 2023. So I will go for the next blood isolate. That would be isolate 4. I will see if the result is available here. And I will see, yes, the result is available and result is R. So to the antidiagram, the result will be fed as R for isolate 4. Similar scenarios, urine ceftriaxone, because here it is anti, the next first isolate becomes isolate 5 and the result goes as R. Why I have shown you this elaborate thing? Because what we have a practice is, when we do an Excel based reporting, we manually thought of the first isolate E. coli entering into the Excel, and we tell our data entry operator to don't enter E. coli for that particular isolate. But that's not the case, because analysis requires all those entities and the next subsequent isolate. So the data entry person must enter all the isolate and then the first isolate is selected. In an Excel based thing, this is very difficult to perform. It's almost either you exclude the other results for some particular drug, start entering entities result, or you given all isolate results, you're not able to put on the first isolate. A software picks it very nicely. That's why I tell that Excel based is too enormous. Go for a software. Now, how an all isolate is collected? So all isolate is a very simple thing. You include all isolate in the data. So how many isolates we have? 5 here. So your denominator is 5. Is it so? The answer is no. Wherever result is not available, doesn't include in the all isolate. So even all isolate, you cannot put denominators in every place. You must exclude your non-available results. Suppose I have 300 E. coli isolates. I cannot make 300 as a denominator for all my antibiotics. Every antibiotic, I first put a filter removing the not available results. And then whatever the remaining ones form my denominator, whatever the susceptible results one form my numerator. This is again a common mistake we do while analyzing our Excel. So in this ceftriaxone, the denominator is 4 because one result is anti. The same way ciprofloxacin, the denominator is not 5, it is 4. Here all results are available, so denominator becomes 5, 4, 4. And then I count the total susceptible results. 1 here, 3 here, 4 here, 3 here and 2 here. That forms the numerator. So this is how even all isolate, skipping the anti results is a must while you prepare all isolate data using an Excel or a software. Software does it automatically. Now this example what I told you is a one patient isolate, but in subsequently you get multiple patients and you have to generate a total antibiogram. So a arbitrary scenario, just try to give you an example. Suppose we have 3 patients and they have respected E. coli numbers, like the first patient is having 5 such E. coli isolates, the third one is having, the second one is having 3, the next one is having 4. So how you generate your antibiogram? In first isolate, you pick the first data like S, S, R, correct? But in all isolate, you count everything. So how many out of these 5, how many are susceptible? 3. Out of these 3, how many are susceptible? 3. And out of these, how many are susceptible? 1. Now I told you all isolate is a isolase based estimate. So the denominator is the total number of isolate. The full number of isolate 5 plus 3 plus 4 forms the denominator. But in the first isolate, your denominator is patient. It is a patient based estimate. So what is the number of patient? 3. So in this, the denominator becomes 3. This is the difference between all isolate and patient based isolate. Now, how we select the antibiotic? All primarily testic antibiotics are included. You cannot include randomly any antibiotic. Whichever antibiotic, you can generate an antibiogram for only those antimicrobial agents where we have all or routine testing. Suppose I have a tendency of testing minocycline only in MDR strain. My hospital tested ceftazidime avibactam only for selective some isolates. Can I generate an antibiogram for those antibiotics? The answer is straight no. If you selectively test some antibiotic in ICU patients, you don't test it in all the isolates. Selectively, you kept some antibiotic like colistin, tigecycline are tested only in ICU patients. Can you generate an antibiogram for those antibiotics? Answer is no. You can generate an antibiogram for an antibiotic until unless it is tested for all the isolates, not selectively. And all the suppression rules, be it selective reporting, be it cascade reporting, all things must be removed by sending your data to the antibiogram. No suppression rules. Suppression rules like selective reporting, cascade reporting, they are good for patient reporting when you report the results for the patient, but you cannot put those rules while you submit the data to the antibiogram. So all those suppression rules must be waived off. Sometimes the LIS, sometimes the Vitek or any other automated system, you incorporate your suppression rules directly for ease of reporting. You must make sure that those suppression rules are waived off while your antibiogram data is created. Then it's very easy. What you include in numerator, I've already told you, susceptible results only. You don't include I, you don't include R. And for certain antibiotics, you have non-susceptible results like pyogens, we have penicillin, vancomycin, we have only susceptible breakpoints. So the other ones, the non-susceptibles, we cannot include them in the numerator. Denominator, everything is accounted for. Special rules are there for certain interpretive criteria like I caret, for urine isolates, Then we have SDD. So all those, we have a special rules. You cannot merge the SDD and iCarrot data into S. They are included, but they are included with a definite rule. You have to separately generate one S% for S and one susceptible percent for S plus SDD or S plus iCarrot. So you'll have one antibiotic represented in two different columns. This is how the rule shows. So primarily we have this for only piptas in enterobacterials and cefepime in enterobacterials. So for those two antibiotic, if you generate an antibiogram, these SDD rules apply. You must have two columns for piptas in enterobacterials and two columns for cefepime in enterobacterials. One is S% and another is S plus SDD %. This is how an antibiogram looks like. Once you prepare it, you must color code it based on susceptibility. So simple color coding you can formulate. This is no hard and fast rule. You can do whatever you want. Like some representation, like for example, more than 80%, you can flag it as a green color. The 60 to 80% S percentages you can flag as a yellow color, and all those less than 60% you can flag as a red color. You can change the coloring. You can make more colors, more fragmentation of colors, but colorful representation is a must for your clinician to understand it better. Otherwise, they won't be looking into the data and see that this percent is better, this percent is better. If you give a colorful, they'll be catchy. They can see that where are the greens, where are the yellows, where are the reds. Okay, so that is easy. Now, enhanced antibiogram, the major difference between enhanced antibiogram and routine is you introduce multiple filters. You remember I have told you that all the things are same except stratified filters. So what are those stratified filters? Plenty of filters. I'll tell you what are the must filter to do. The most important filter is specimen filter. Generating antibiogram for blood, for urine, for pus, for other specimens, for respiratory tract infections. Those are must. Okay, then for a specific locations like generating a specific antibiogram for ICUs, IPDs, OPDs, that's a must. Generating antibiogram for your specific facilities like medicine, surgery, pediatrics, maybe oncotransplant, those are must. Okay, then you can also, if you have a facility to cater the patient's admission data and the sample collection data, you can also give a healthcare associated or community acquired antibiogram, because for antibiogram, a 48-hour rule is enough. So if you have a gap of admission to sample collection 48 hours, that goes to CA, more than 48 hours goes to HA. So even HSC antibiogram, if you have admission date information, is a very useful thing for a clinician to decide how to treat a healthcare associated infection and how to treat a community acquired infection, because their susceptibility is going to vary. So one antibiogram doesn't serve purpose for both of them. Now we have a concept of combination agent antibiogram. Like for example, you can represent, like in this example, this is how we represent a combination antibiogram. It is generated for Pseudomonas. We have Cipro, Ceftazidime, Imipenem, Tobramycin. We also have a combination agent antibiogram like Ceftazidime and or Ciprofloxacin. This is how we represent a combination agent antibiogram. How these combination agent antibiograms are created, I'll just give you a brief example. Like suppose for a particular isolate like Pseudomonas in this example, I'll try to find out how many are only ceftazidime susceptible, not to ciprofloxacin. For example, suppose the data came as 30%. Now I'll see how many are susceptible to ciprofloxacin but not to ceftazidime. Suppose the data came as 30%. Then I'll try to find out how many both are susceptible, ciprofloxacin as well as ceftazidime, say 26%. So how my combination agent antibiogram will be represented, where the point will be ceftazidime and or ciprofloxacin, means either ceftazidime susceptible or ciprofloxacin susceptible or both susceptible. What you have to do is you have to add these percentages and that will give you 86%. So this is how a combination agent antibiogram is generated. Individually you calculate only first antibiotic, only second antibiotic, and both first and second antibiotic percentages. You add them and you get a combination agent antibiogram. This is very crucial if you have a, and this should be done only for those combinations which are very common in your institute. If your institute uses third generation cephalosporin plus amikacin very commonly, then you should use it. If your institute uses a third generation cephalosporin plus quinolone very commonly, then you should give in your antibiogram the combination agents. They should see what is the benefit they are getting from using in combination. If the benefit is not much, there is no use of using it. Okay. Subtraction antibiogram is something which is generated to subtraction antibiogram. The other word is a comparative antibiogram. So if you want to compare your last year data of susceptibility with your current data, you want to compare your susceptibility in your institute. Suppose my ICU versus my IPD, my ICU versus my whole hospital. I want to compare my antibiogram with the neighboring hospital. I want to compare my antibiogram with the national database. All those comparisons can be done using this subtraction antibiogram. How it is done is, what you want to compare from what. So whatever you want to compare is your first digit. You minus it from whichever you want to compare. So suppose I want to compare my ICU data from my IPD data. So my ICU susceptibility percent minus my IPD susceptibility percent will give me a combination subtraction antibiogram. Now if that data is positive, it means you have an improvement in susceptibility. If that data comes out to be negative, it means it's a inferior, it's a deterioration in the susceptibility. So a data which is plus in subtraction antibiogram, if you're generating a yearly antibiogram comparison, it means the susceptibility for that particular drug has improved from last year. Same way, if you generate antibiogram subtraction antibiogram and it came as a negative in subtraction antibiotics, that particular drug has become more resistant compared to your last year. So that comparison subtraction antibiogram generation is again a very crucial method. We usually represent is as a color. The plus ones you represent as green, the negative ones you represent as red for easy picking. The last one is of antibiogram is rolling antibiogram. I told you rolling antibiogram is, the importance of this antibiogram is you need not wait for 6 months. Suppose I am in February, then I have to wait for 10 months to get a fresh antibiogram, and that's a long distance. So I do not wait that long. Suppose I am in midway somewhere in September. Now I am left either to wait for 4 months to generate a new antibiogram, or I have to use a 7-month or 8-month old antibiogram. So this is not good. So for that solution comes the rolling antibiogram. There are 2 times of rolling which is usually done. Either the rolling is done on a first of a month, that suppose you are trying to see your antibiogram on 15th of June, it will show you data till 1st of June. From the last year 31st May to 1st of June, this is monthly rolling. And then we have one method of rolling which is done on a daily basis. So you want to see today, so yesterday to backtrack 1 month, 1 year data, that will be available. So daily rolling is one way antibiogram software does, or a monthly rolling is also done. So the last antibiogram is syndromic antibiogram. Syndromic antibiogram is an arbitrary antibiogram. Like for example, you want to generate your antibiogram for sepsis. What you do is include only blood system isolates, blood culture isolates. You want to generate an antibiogram for community acquired pneumonia. What you have to do is you have to include LRT isolates, AST data, and make sure that those are community acquired, means date of admission to date of sample collection less than 48 hours. What you get is a community acquired antibiogram. You want to generate a ventilator associated pneumonia antibiogram. Then how you do it? You include only EP secretions and tracheostomy tube secretions in the isolate, and put a healthcare associated filter, means admission date to sample collection date more than 48 hours. What you get is a ventilator associated pneumonia isolates. Same way you can generate for UTI, same way you can do for wound infection. So when you filter out your isolate, you put on some additional criteria, what you get is a syndromic antibiogram. This is very important antibiogram to generate in your institute. So this is all about antibiogram. I'll come to my second part of the talk, that is pathogen-directed antimicrobial stewardship round. It's primarily a round, but it can also be made in an audit format. So what about this? How this pathogen-directed AMS came into picture? So we all know about prospective audit and feedback. This is a very important and very crucial method to implement AMS activity in your institute, how we carry out this prospective audience feedback, how the base of carrying it is, you target a location, be it an ICU, medicine ICU, surgery ICU, or any other ICU. You target a particular ICU. Every day the AMS team with clinical microbiologist goes to that team, sees all the patient. Suppose you have a 30-bedded ICU or a 20-bedded ICU. Every day you go to that particular ICU, you see all the 20 patients or all the 30 patients on a daily basis, right from day of admission to the day of discharge or their demise. You follow up that patient on a daily basis, and then you give your antimicrobial advice, therapeutic advice to the clinical team. This is the gold standard of performing rounds. But is it feasible? Because when you have to go daily to an ICU, that too covering all the patient's bed, it's a tedious process. It's a time-consuming process. It's a manpower, resourceful patient process. So even if very good, performing it to multiple locations, it's very challenging. You cannot do it. You can target it 1 or 2 ICUs, but you cannot do it on a global way. The solution to this is what I'll be suggesting in the PDMS round. Another point of importance is, even if we talk about diagnostic stewardship, right test in right turnaround time, but whether that is going to create an impact, the answer is maybe no. Because even if your AST result is made available to the clinical team, the action taken on the AST report may be prolonged. You may have reported your reports, AST reports, in time, but your reporting is not equal to patient getting the treatment that you have reported. So this lag, how you address this lag? This lag is how we address with the pathogen-directed AMS audit. So how we do a pathogen-directed AMS audit, many of us will be doing it. It is primarily something which a clinical microbiologist can very easily do without any other support. When you report your AST, all those isolates which come as culture positive, you go and follow those patients. This is many of us do, but this can be done on a routine basis. Okay, it serves 2 purposes. It addresses your stewardship goals, as well as it makes sure that your AST report counts. It makes sure that your AST reports are taken well. Now, how this kind of rounds we do? So the first level is verbal communication over phone with the clinical team. As soon as your reports are available, we should communicate telephonically to the treating team. But the problem is, this communication can be done only when you have per patient sample clinician's number. So that can be introduced in the sample requisition form, clinician's contact number, so that using that we can contact and give them our inputs or the susceptible results. Now, the second level of reporting is in-person verbal communication, where you go on an AMS round, you talk directly to the clinical team and solve their doubts, address their issues. They'll have some patient-related queries, you'll address those. And then we and the clinical team come to a middle ground on what should be the appropriate antimicrobial therapy in those patients. But this can never be done if you don't know where the patient is. So location information of the patient or tracking the patient in the hospital using your HIS is a must. You can have that information also in your patient form. Okay. The last part of this, conducting this, is usually on the basis of written communication using a AMS form. Every institute must generate their AMS advice form, in which specific advices on antimicrobial therapy must be written with basic patient details, and this communication must be confirmed to the clinical team. Why we need this written? There are 2 specific reasons for that. Suppose I have already communicated in person to the clinical team. I went to a round, I found them, I talked to them, I told about the therapy. Clinical team is not the same. Throughout the day, the team changes. You may have talked to a senior resident, you may have talked to a junior resident, you may have not talked to the clinical, the consultant. So your GR may not have updated the information that you have given to you to the consultant. How the consultant will be knowing, how the other faculty attending the same patient will be knowing. This is possible when you stick in the patient's case sheet the advice form. This is my antimicrobial advice. institute's name, the team member's name, all those can be written. This makes sure that everyone who attends the patients, who sees the case sheets, gets the advice from. This is one importance of putting a written thing. The second advantage of putting a written advice form is documentation. You have told verbally some antibacterial advice. Subsequently, you can back down from advice, change your advice, tell that no, I have not told this like that. How the this trust comes that what you would tell, you stand to it. When you put the same advice in the seat, in your advice form, that builds a trust, that gives a weightage to what you say as an advice. That is why even if you give a verbal advice to them, always include a written advice form and stick it to the patient's wall. Okay, make it colored so that it's easily visible for them. Now, this was about advice, but I've told you this is a round which can be converted into an audit also. But if you want to convert into an audit, then you must make sure that you evaluate it. You make sure that it is measurable. How to make sure it is measurable? Your advice should be in a format which is measurable. So how to make your advice as measurable? You can categorize your advices into multiple categories. What are the various categories? Like for example, you can categorize as empirically no antibiotic, start antibiotic. So start antibiotic advices. Patient is not getting any antibiotic. You went to the patient, you saw that the culture is significantly positive. You know the susceptibility, you went and tell them the patient is not getting antibiotic, add this antibiotic. These kind of advices are start antibiotic. You went to the patient, you saw that the correct antibiotic is already going on in the patient. Then the advice will be continue the same antibiotic. Okay. So you specifically classify your advice. Next antibiotics, suppose you go and see that patient is not getting the correct antibiotic. Then the first kind of advice is change of spectrum. What we mean by change of spectrum, patient is getting some gram-positive antibiotic, vancomycin. You got an E. coli, which is a gram-negative, ceftriaxone susceptible. So patient is getting a completely different spectrum of antibiotic, a gram-positive spectrum, getting a gram-negative infection. These kind of advices can be labeled as change of spectrum. Now, suppose patient is getting a gram-negative antibiotic, but not the kind of advices. We usually classify in two types, either a escalation advice or a de-escalation advice. Okay, now I would like to focus on that. Usually when we understand, how we understand the term de-escalation. The term de-escalation is usually taken into account by, we think that some higher generation antibiotic is going on and we asked to bring down the antibiotic. This is de-escalation. This is not de-escalation. This is just a very small part of de-escalation. So what are the various de-escalation advices? De-escalation advices can be multiple. The most important, what we understand is what we call as narrowing of spectrum. Meropenem is going on, you went and advised piptose, you went and advised ceftriaxone. Stop meropenem, start ceftriaxone or a lower generation antibiotic. This is what we call as narrowing of spectrum. What are the other de-escalation approaches? One such approach is overlapping spectrum. 2 gram-negative coverage for the same patient antibiotic is going on. And you go and tell that 2 are not required. If patient is not critically ill, hemodynamically unstable, 2 are not required. Stop 1, continue 1. This kind of thing is what we call as overlapping spectrum, removal of overlapping spectrum. Then the third kind of de-escalation approach is removal of redundant antibiotic. What are redundant antibiotic? Patient is getting I can only for some minute. So patient is getting vancomycin plus meropenem, for example, and the patient came as susceptible to E. coli, susceptible to meropenem. Now, whether vancomycin is going to act on E. coli, the answer is no. It's a gram-positive statement. So, any such antibiotic which is going on, which is not going to cover your organism, all are redundant antibiotic. This is one example. Gram-positive, gram-negative antibiotic going on. You got a gram-negative, gram-positive, you want to stop. Fine. Another type of 2 gram-negatives are going on, but one of the gram-negative is intrinsically resistant. For example, suppose the patient is having a bloodstream infection with Klebsiella aerogenes. The patient is getting ceftriaxone or ciprofloxacin along with amoxiclav. Now, whether amoxiclav is going to act on Klebsiella aerogenes, answer is no. They are intrinsically resistant. Pseudomonas, same scenario. Then all amoxiclav, where they are intrinsically resistant to the actual pathogen isolated, these are which termed as redundant antibiotic. So those redundant antibiotic removal is also part of de-escalation. The next kind of de-escalation is stop antibiotic advices. Patient is doing fine, all the biomarkers coming fine. You tell that these antibiotics are not needed. Surgical antimicrobial prophylaxis. You go on day 2 of the patient, you find a patient which is still on antibiotic, you give the advice on stopping the antibiotic. Those are stop antibiotic advices. Then IV to oral switch is also a subtype of de-escalation approach. The switch can be to different oral drug or to the same oral drug. Patient being treated on IV ciprofloxacin for a UTI, you tell oral nitrofurantoin. This is also IV to oral switch. Patient is on IV ciprofloxacin, you tell to start oral ciprofloxacin. That also is an IV to oral switch. So IV to oral switch can be done for the same antibiotic, can be done for a different antibiotic. Both are totally okay. You can also give administrative advices like loading dose advices for colistin and tigecycline. You can give, if you follow the antibiotic quite well, you can also give renal dose adjustment advices. You can correct their frequency of administration. You can give infusion related advices specifically for beta-lactam drugs, specifically in beta-lactam, cefepime, piptas and carbapenems. They must be given as an extended spectrum, extended infusion over 3 to 4 hours. So those kind of administrative advice you can also give while beyond the round. On persistent advices, people will start listening to your advice. Now, so why we need this AMSP round? We need it to make sure that the clinician's knowledge on antibiotic is improved. The clinician will be having many doubts on antimicrobial therapy. That will be improved when you go and talk to them in person. Your antibiotic result will be aptly translated in the patient's therapy. It's not just on pen and paper AST report. Your actual report is translated properly. Improper use of antibiotic definitely will be taken care of, and considered to pass, it is less labor intensive. You are targeting only specific patients in specific locations, so you are able to cover more locations and a more focused antibiotic treatment. But there is a downfall of following this. What are the downfalls? Because you are following only culture positive cases, so you will be missing those cases where cultures are turning out to be negative and still patient is being pushed with antibiotics. And follow-up is often difficult. If you're doing an audit, the recommended follow-up is somewhere 24 to 48 hours. So you go and do the audit, give your advice, document your type of advice, follow up the same patient once at 24 hours or 48 hours to see what is your compliance. If your compliance is good, you note down the compliance. If the compliance is not there, then you find out the reason for non-compliance, why they have not listened to your antibiotic advice. That's it.
Thank you, sir. I would like to request Parijat ma'am to conclude the session.
Hello.
Hi, good morning, everybody. A very, very exhaustive and elaborate presentation you have given. In fact, as personally, I was having a talk with doctor. He said that it really takes a workshop on antibiogram preparation. So, but he has given us a bird's eye view on the whole of the program of antimicrobial antibiograms, forming the antibiotic policies and the antimicrobial stewardship program. And, you know, it is really a challenging thing. If each one of y'all ask yourselves, how very much can you be in association with the clinicians and then report, have a communication with them and then come to some conclusion on the antimicrobial policies? Many of us are doing this, but it is a real challenge. And as I was also having a personal talk with him, we can take this thing step by step and then we can have it. So finally, what is important is patient safety. We are working for the patient safety and patient's betterment. So one question I have with you, there are some institutes wherein we do not get 30 isolates per year also. We may have to extend the time limit or months for getting that isolates. And if we have 20 isolates or less than then, how should we work out on that? Like,
Yeah, there are a few rules to let down. The first and the most accepted rule is clubbing the yearly data. So if we have 20 or 15 odd isolates in a year, we can release 2 yearly antibiogram for those and agent only for Vibrio, Haemophilus, Salmonella, Shigella, all those things. 2 year, 3 year even is acceptable. Another way out is you can release the antibiogram with minimum number of isolates as 12, 20, 15 and give a comment on the back that it is calculated on less number of isolates significant. These two are the most common methods we employ.
exactly. We can have that comment and we may have communication with them saying that these organisms are sensitive or resistant to this and that will be betterment for the treatment protocols. So finally, you have heard each and everything about this, and we would request him to come to us some other day to have a workshop on this, or we may associate with him for having a detailed workshop. And it is really, really helpful to all the budding microbiologists who are over here who can start thinking on this. Thank you very much, and let us have a big applause for him. Thank you, and I thank the organizers to have us as a team being the chair for this session. We are really proud and elated on this session. Thank you so much.
Thank you, ma'am. I request Dr. Kanu Patel, sir, to felicitate Dr. Ketan, sir. I request Dr. Sangeeta.
Thank you so much, chairpersons and Dr. Sangeeta. Those candidates with the poster presentations who could not present their posters yesterday, they are supposed to move to seminar room number 7 for poster presentation. Any candidate who could not present their poster yesterday can move to seminar hall 7 for poster presentation. Thank you. स्क्रीन भी दिखा रहा है, लड़कियों ने चल के भी दिखा दिया है कि सारे एमडी डॉक्टरों के बीच में अपने मुन्ना भाई एंड सर्किट आ गए हैं.
सर्किट सुनना, बोलो ना भाई, तो तुझे पता है ये माइक्रोबायोलॉजिस्ट क्या करता और क्लिनिशियन उससे क्या मांगता?
नहीं भाई,
अरे वो अस्थाना ने मेरे को प्रोजेक्ट दिएला, अपनी तो वाट लग गई है।
क्या बात कर रहे हो भाई, बजा दूं इसके कान के नीचे?
नहीं रे, इनकी को भी तो इम्प्रेस करना है ना, प्रोजेक्ट तो मेरे को करना पड़ेगा रे।
आप टेंशन मत लो भाई, अपने नेक्स्ट स्पीकर है ना, उनको सब सिखा देंगे। हार्दिक भाई बताओ ना।
I know the mic is also pulling my legs now. I'd like to invite our chairpersons for this session, Dr. Kairavi Desai ma'am, Professor and Head Microbiology Department. Professor and Head. Sorry, but I'm guessing that I'm audible to the last person as well. I'm famous for this and I am not something is wrong with the mic. I hope I am audible now. Yeah, so once again, I'd like to invite Dr. Jayashree Pithani ma'am, Professor and Head Department of Microbiology, NHL Medical College. I don't skip my duties, sir. Dr. Mansi Shah ma'am, she's a clinical microbiologist. Good morning, ma'am, and welcome to the stage. It's my honor to invite respected Dr. Atul Patel sir for this session. If maybe we have Dr. Atul Patel sir on stage. I request Dr. Mansi ma'am to introduce Dr. Atul Patel sir.
Hello, good morning, ma'am. Yes, sir, does not need any type of introduction, but sir is the Director of Infectious Diseases Clinic, Vedanta, Navrangpura, Ahmedabad, and visiting Associate Professor in Medical Division of Infectious Disease, Maserati Medical College, South Florida, USA, is one of the author of Global Guidance of Mucormycosis and Cryptococcal Disease. Numerous publications and chapters in prestigious book show his commitment towards the field. Co-chair of Asian Fungal Working Group, ISHAM Working Group, he has been strongly in the asset of ICMR as well as Government of Gujarat during COVID crisis.
Yeah, good morning and thank you very much for inviting me to speak on this very important topic, because I mean the crosstalk between the microbiologists and clinicians is extremely important. So I don't have any financial disclosure to make for my today's presentation. Okay. And whatever I'm going to speak to you in next 45 minutes, these are my personal views. So many of you may not agree with my views, so that's fine. So what could be the ideal situation? Like, what is important? Like what should be the relations between the clinicians and the microbiologists? The most important thing is that they have to work together. This is extremely important. And when the microbiologist and the clinicians, they are working together, it maximizes the clinical value of the diagnostic microbiological testing. So this is, I think, you can reflect all this, like when you have a maximum and the most important, the information that is translating into the clinical practice, then the end result should be the patients will be benefited, right? So this is extremely important that they have to work together. And there should be bidirectional communications. Even the previous speaker also spoke about the same thing, that I mean, the result should be discussed with the clinical team as soon as possible. So maybe on the telephone, or if you are within the hospital, maybe in person. But not only that, the microbiologist should talk to the clinicians, but clinicians also should talk to the microbiologist before he is sending a sample. For example, the patient is undergoing some craniotomy or the stereotactic brain biopsy or the sinus surgery, and the clinician is expecting some, or clinician is suspecting the microorganism, say for example, some Dematiaceous fungi or the Mucorales or some any things like nocardia. Then clinicians should talk to a microbiologist that, look, my patient's surgery is posted at so and so time, and I'm going to expect the sample should reach to the microbiology lab around 5 o'clock or whatever time that you are expecting. This will help microbiologists to be ready, and this can be has a very important the role in the management that if the patient is undergoing stereotactic biopsy in the evening and the microbiologist is giving a report within 30 minutes that direct microscopy that this is a nocardia, your treatment changes, right? And it's very responsive organisms and patients can get early targeted therapy for the brain abscess. So it should be a bidirectional communication that not only clinicians or the microbiologists, both should talk to each other. So so this is what we have discussed. So this slides or this table I have taken from the Principle and Practice of Infectious Disease, the Mendel's textbook. And it has categorically put this table about the microbiologist's responsibility. And this is the same standard responsibilities that the microbiologist should provide the appropriate menu for the clinician's needs. So if the catering, the clinical department is having an infectious disease and they are expecting so many opportunistic infections, including fungi, the rare uncommon organism, uncommon opportunistic infections, apart from the standard bacterial infection, then all these tests should be available into the microbiological facility. So if it is not possible within the lab, then the second line also is very important, that this microbiology laboratory should have a good relationship with the tertiary care laboratory or the referral laboratory, where the tests can be performed, like these are the rare or the uncommon tests which the clinicians required. So it should be performed at the good reference lab, and the results can be available soon to the clinicians. So I think this is very important. It's not that you have to perform each and every test, but if you are establishing a good relationship with the tertiary care or the referral lab, probably that is also very helpful to a clinicians to start appropriate therapy early. The microbiology lab should also provide information about the cutoff time. Say, for example, some uncommon test like galactomannan or beta-glucan or any other test, or the PCR, the molecular diagnostic test. The appropriate cutoff time should be given to the clinician, that daily we are performing this test in 2 o'clock batch or something like this. So this will help clinicians to send the samples early. So these samples can be taken into the same day batch, or whatever is convenient to the clinicians, right? So this is very important, that all the information should be provided to the clinicians. So clinicians can also organize sending the test in the appropriate time. So there are several other points that, I'm not going to discuss each and every point's detail, but what the important thing that we expect from the microbiologists. So what we expect from the microbiologists is that we expect that whenever we are sending a biological specimen to a microbiology lab, all the basic tests or the basic staining, I expect that microbiologists should perform. So even though I have written the routine and microscopic examination, this microscopic examination should include everything, from the wet preparations to the gram stain, sedin stain, modified sedin stain, everything. There's no need to, describe in detail that I need KOH, I need modified sedin stain, or I need gram stain. Why this is important? Because many a times, clinical presentations of variety of opportunistic infection has changed over a period of time. So in last more than 10 years, I'll tell you that in most of my patients who has culture positive tuberculosis, they do not have fever, they do not have constitutional symptoms. They received a diagnosis of tuberculosis accidentally by routine radiological investigations, or from the physical examination, or from the laboratory test where the ESR is very high. And the primary doctor is chasing ESR, look for the reasons for high ESR, and found some lymphadenopathy where patients do not have fever. So majority of my patients in last decade with culture positive TB, they do not have fever, right? So, and we were taught that the tuberculosis is generally present with fever, constitutional symptoms, weight loss, anorexia, and all these the symptoms, right? So this is changing epidemiology. So the information from the clinical specimen, right? Direct microscopy probably is very helpful and can pick up AFP, can pick up nocardia, can pick up fungus and other things. The second important, the positive things that you will get from performing all the tests from the clinical specimen would be, it can change the clinician's request for a culture, right? Suppose if I have sent a clinical specimen brain abscess sample for a bacterial culture, suspecting that this could be some bacterial or the pyogenic abscess, and the direct microscopy showed the multiple fungal pathogens, especially the mycelial stuff. And if I have not requested fungal culture, then microbiologists can call a clinician that look like the direct microscopy is full of mycelial structure. So fungal culture would be very helpful. If he's looking at a ZN stain positive, then change the culture request from a routine bacterial culture to the TB culture. Like this is how like microbiology lab should interact with the clinician, that even though you have not requested this, the direct microscopic examination is showing AFB or the fungi, and you should request or you should process this sample for a fungal culture. Many times what happens, the report is generated and after 48, 72 hours, the patient came with the report and report is showing AFB and we have not requested for the TB culture, right? Because TB was not suspected. I told you that the standard classical presentation of tuberculosis is no longer seen in clinical practice. So I think here, like the microbiologists can play a significant role, that you need to change your culture request, and from bacterial culture, change it to some other cultures. So this is how, like, let me give you a real examples in my clinical practice. This slide is from my the talk at which I took at the Medical Mycology Training Network in Malaysia. The topic was 10 common mistakes in clinical mycology. So that was my topic. So this is a patient from Gandhinagar who presented with the fever, weight loss, and all the constituent symptoms. And the CT scan showed bilateral enlarged adrenal glands. Here you can see that the adrenal gland size is almost 1/3 size of the kidney, bilateral, both the sides. And the contrast study shows there is areas of hypodensity in between, right? So this looks like some necrotic areas. So hypodense area into the adrenal glands, and persons coming from India, fever, constitutional symptoms, weight loss, and enlarged adrenal is tuberculosis, right? So TB was the first diagnosis. So we did the CT guided adrenal biopsy and requested gene expert TB culture and histopathology. It's a standard request from just to identify the tuberculosis. And the gene expert was negative, but histopathology showed that adrenal gland was full of his cells. You can see that the entire adrenal gland was studied with his cells. So here, like when I have not requested for a fungal culture, but if the microbiologist is looking at the sample and says that this is full of his and AFP was negative, I think this specimen, the adrenal gland biopsy specimen, should be subjected for a fungal culture, and histoplasma can be very well easily identified, though this patient has responded nicely. But I think, and this is an example where the microbiologist can influence the clinician's request, that here I'm looking at something and you have requested this, though TB was the first diagnosis, but histoplasma can also give you all the fevers, constitutional symptoms, weight loss, and enlarged adrenal glands in India. So again, this was discussed well, that microbiologists should inform clinicians about the critical reports, especially when the blood culture flags, right? This is very important. The reason is that when somebody is having a bloodstream infection, the mortality rate is very high, like especially with the gram-positive organisms and gram-negative organisms also. If you are looking at the yeast into the blood culture, that means Candida species, then the mortality is 40%. Right? So nearly half of the patient will die. So your job or your responsibility is that if you are looking at the yeast or the gram-positive organisms like Staphylococcus or any other organism, you should contact clinicians immediately that your blood culture the bottle has flagged and it showed gram-positive bacteria or the yeast or whatever it may be. So this can save lots of time. There are multiple studies which says that early administrations of effective antimicrobial therapy saves the life. It reduces the mortality. Not only reduces the mortality, but it reduces the morbidity and the hospital stay also. Right? So this is how like you can improve the management of the patients. If isolation has highly infectious pathogens like Brucella or any other organism, this is also very important, that if a patient is having some contagious illness, then this can also have an impact on the hospital infection control, and that can also help to reduces the risk of transmission of this highly contagious or the infectious disease to the medical and the paramedical staff. So this is again very important things to understand. So another, I mean, this is a simple repetition that, I mean, about the isolate that the microbiologist has isolated and which has got some clinical relevance. Many times, like what happens, the clinicians in a patient who has diarrhea in hospital, they are sending stool routine microexamination as well as the stool culture, and we know that the entire GI tract has abundant flora, right? So invariably you are going to grow some gram-negative organisms, either E. coli or some Klebsiella oxytocin or something like this. And you also report the susceptibility to all this, the GI flora, and clinicians, they started tetracycline or any other high-fi antibiotics for the treatment of this. And we know that these are the part of normal flora. So I think you should also, I mean, mention that though the culture is positive, we have isolated normal GI tract flora, the normal, the respiratory flora, whatever like, right? So this is, I think, very important. Keeping a line probably will help clinicians, or it will give a message to a clinician that, am I treating a normal flora to this patient, and is it a real pathogen which is producing diarrhea? Because antibiotic associated colitis and antibiotic associated diarrhea is not uncommon, because we are using broad spectrum and combination antibiotics. Antimicrobial abuse or the overuse is very common in our hospitals, right? So invariably patients can have colitis following the use of antibiotics, but it does not mean that you have to switch to the tetracycline or the colistin to treat that normal flora, which has now developed resistance. The another important thing is that, like, whenever you are looking at some isolates like methicillin resistant Staphylococcus aureus isolated from the bloodstream, what I expect that, like, when you are reporting that the patient isolate is sensitive to vancomycin, linezolid, ticagrelor, daptomycin or whatever, but when it is isolated from the bloodstream, I think the vancomycin MIC should be reported. And this, why this is important? Because like less than 2 is generally reported as a susceptible. But when I am treating MSS or MRSA bloodstream infection where the vancomycin MIC is between 1 to 2, the chances of treatment failure is very high. Right? And you know that vancomycin is drug of choice for when somebody is having MRSA bloodstream infection. This is the drug that you are going to use it. But when the MIC is between 1 to 2, it is very difficult for a clinicians to achieve the adequate exposure of vancomycin to treat that MIC between 1 and 2, right? So this is how, like, it will help clinicians to report. And many laboratories, they just report clindamycin sensitive, vancomycin sensitive, but they will not provide MIC. I think this is very important, that you have to perform additional testing, e-test, or if you have I-tech, then perform a good MIC and report it. This is very important because the MRSA is a life-threatening condition. And if you ask me, like, which organism, like, when you are treating in your patient, you are afraid of most, I think I'll tell you that I'm afraid of MRSA treatment. This is the infection which is extremely difficult to eradicate from the bloodstream, and the metastatic lesion is very common. So your patient invariably will end up with either endocarditis or vertebrodiscitis or any other distant metastatic foci. And if you are not providing appropriate proper antibiotic therapy with appropriate exposure, then your patient is going to die. Right? So MRSA is extremely important. Similarly, vancomycin intermediate susceptible or the resistance organisms. This is how you can contribute to the patient's clinical management. And this will help to reduce the treatment failure. So even though, like, you are using vancomycin, you said that, I mean, I'm using a correct antibiotic. Vancomycin is reported to be sensitive, but it is associated with the high treatment failure chances. Another thing that you can contribute in the patient's, not only in the patient's management, but you can contribute to the society, is that you should be alert and report any outbreaks that you are looking at into the samples that are coming to your laboratory. So you should talk to the clinician, and if required, you can talk to the corporation also. For example, if you are getting the clinical samples from one of the unit and you are getting NTM isolation from that particular unit in a short period of time, large number of patients who develops NTM infection, it is your duty to talk to that clinical team that, look, I have received 3-4 samples in last couple of months, and all these 3-4 samples virus has grew NTM infection. That means that you should take care of your hospital infection control practice and make following changes or the necessary changes which can reduce the NTM infection from your hospitals. I think this is very important. It will not spoil your relationship with your the clinical team that is giving you a sample, but it will help that your clinical team to provide a better clinical management to their patients and reduces the risk of morbidity because of the NTM infections into their very expensive or the complicated surgical procedures, right? So this is very important that you should communicate with your clinical team. Similarly, if you are isolating Candida auris from any clinical specimen, either it is a urine, blood, or any other samples, I think it is your duty to talk to the clinical team, not only clinical team, but if you are getting a samples from one of the hospitals, talk to the hospital infection control practice that, look, Candida auris has been isolated from one of your patients, and this is very significant because Candida auris behaves like a bacteria, gram-negative bacteria, and you expect a large outbreak in a short span, right? So you have to make all the attempts to reduce the chances of a major outbreak because of the Candida auris. Why I compare Candida auris with the gram-negative, that the Candida auris can emerge into the multiple antifungal resistance while on treatment, even though to begin with, if Candida auris is sensitive to, say, for example, voriconazole, echinocandins, and amphotericin. On treatment, the Candida auris can lead to the emergence of resistance to the treatment that patient is receiving and produces treatment failure. And the chances of transmission from one patient to the other patient is extremely common. So it can give you a large outbreak in very short time span. So if you are isolating Candida auris, please talk to your clinicians and hospital infection control team and act very fast to reduce the transmission of this Candida auris. The another thing that you can do, that was done in Baroda also, that before I think 6 or 7 months, Baroda has a large outbreak of community acquired, not community acquired, it is always the community acquired, the enteric fever, which was resistance to the standard drug, that is ceftriaxone. And it was reported well and it was studied well. So I mean, this will help to reduce the outbreak of the common infection in a community with very high resistance, which was not there, right? So you can, or the corporation can take appropriate precautions to reduce the chances of transmissions of this enteric fever to the other people. Now coming to the another important thing. So do not expect that all the clinical teams or the clinicians are scientists and they are researchers, right? We are just simple clinicians. We make a diagnosis and we just treat the patients. We are not researchers. So whenever you are sending a report to a clinical team, especially when you are asking for the molecular diagnostic, please give a good summary, interpretable summary that clinicians can understand that, look, from my clinical specimen, you are looking at these organisms. We know that molecular diagnostic has a very important role in last almost 5 to 7 years, right? So most of the clinical clinicians, they are started using molecular diagnostic for the management. And again, very important thing is the development of multiplex PCR. The syndromic multiplex PCR has made the job of clinicians very easy, and they are very easily interpretable also, right? If you are using the film array for respiratory infections or the GI or the joint infection or the meningitis encephalitis panel, it's very easy that you have isolated HSV from the meningitis panel, so patient is having HSV encephalitis. And similarly from GI tract, if it is a Vibrio cholerae, then it's a cholerae, right? So interpretation of multiplex PCR is very common, but there are clinical situations where we are getting a rare or uncommon clinical conditions and we are subjecting these biological samples for metagenomics or next generation sequencing or the whole generation, the whole genome sequencing, or to be specific like 16S rRNA or the ITS sequencing for fungal pathogens and the 16S for bacterial pathogens. Here, like when you run a test, you are going to get a large amount of information from the genomic material from the biological sample. But whenever you are reporting this, like be very specific, give a great summary so that clinicians can understand like how to interpret this report. Let me give you a recent example. This is a gentleman from Jamnagar who has chronic pyogenic meningitis following lumbar puncture. Right, so we know that like lumbar puncture is very safe, but rarely you may introduce some organisms while performing a lumbar puncture and giving anesthesia, and patients may have funny chronic pyogenic meningitis. So this patient has received empiric antibiotic therapy, received empiric anti-TB therapy for this meningitis without any response, and persistent symptoms, and the CSF is showing persistent cells, increase in the protein, low sugar, and predominant polymorphonuclear leukocytosis. So when patients came to us, like we sent it for, I suspected that this could be a gram-negative pyogenic meningitis because E. coli is very common pathogens and which produces low-grade chronic inflammatory changes. So with this in mind, I send it CSF for 16S rRNA as well as the ITS, just to, rule out any fungal pathogens. And look at the report. So this is the first page of the report. This is the ITS, and this ITS also reported so many things. For me, it is extremely difficult to understand, like what should I do with this report? And this is a 16S rRNA. Look at this. How to interpret this? Not only this, like this report also includes several charts, because we know that the molecular diagnostic will give you variety of charts and graphs. It is not possible for me to understand like what this graph includes. How do I interpret these numbers also? I don't know, because I'm not a technical person, right? This report also includes variety of QC tests that have been performed, methodology of the test. I am not interested in methodology. Mane rotla thi kaam chhe. I'm not interested in tap, right? How many tap you did in your laboratory? That's fine. I need a rotlo. I am hungry and I want to eat, right? So कहना क्या चाहते हो पता ही नहीं चलता है. Like even when you look into the 6, 7, 8 pages report, I can't understand this. Recently, I again sent one biological samples for the ITS evaluation, and look at this. This microbiologist says that look, out of this sequence analysis, this is 3 days back report. I am suspecting that your isolate is having these organisms. This is specific report generated by another microbiologist, right? So I think whenever we are sending metagenomics or NGS or 16S rRNA, I think it should be very specific, because I can't understand those numbers. You have to tell me that from this biological specimen, this is a very likely pathogen which is producing infection. So clinician's expectation is that a laboratory services that clinician can trust, right? So this is very important. And these are not my statement. This is from the NHS UK. It says that more than 70% of the medical decisions in the hospital, they rely on the lab results. And this is true also, right? We have to rely on the medical the results. So you have to provide a trustworthy medical reports or the microbiological reports. There should be no shortcuts. This is very important. And we expect that you are going to use the approved and the validated kits, because you may found unvalidated or the shortcuts, especially in the molecular diagnostic case. The homebrewed kits are rampant. So you are going to get a funny results. There are multiplex PCR, unvalidated PCRs, and several patients, they are coming to my clinic with all these unvalidated multiplex PCR showing variety of organisms or the multiple organisms, 3, 4 organisms together. How to interpret this? I don't know. So I expect that you have to use approved and validated kit. So we know that the reliability of this test is 98%, 99% specific and sensitive. For example, film array, right? So it has been robustly tested. Then US FDA has approved this test for making a diagnosis of so-and-so infections. So I think this is very helpful. And no cost cutting. This is very important. The interpretation of microbiology depends entirely on the quality of specimen that you are going to receive, right? So if you are not going to receive a great quality of specimen, say for example, urine is not being collected as a midstream, or the sputum is given with the contamination with the oral flora and other things, then the interpretation of this test is very difficult, right? So midstream urine is not used, which urine is already the surrounding skin, and the interpretation of organisms would be very difficult. It may not be a true pathogens for the patient's symptoms, right? So the quality of specimen that you are going to receive is extremely important. So always be in touch with your clinician and inform that if you are sending a urine, please be specific that you are going to accept only midstream urine. So that will help that you are going to receive a good quality specimen. So provide a very clear guidance to your clinicians that will help to receive a good quality specimen. The turnaround time should not be the problem just because the technician is not available or the microbiologist is not available, especially for a very valuable clinical specimens, right? Like stereotactic brain biopsy or some operative procedures has been performed and the sample is going to microbiology lab. The lab should also perform the crucial tests, like I gave you an examples about the MRSA. So perform vancomycin MIC. This is extremely important for a clinicians, right? Candidas, when you are reporting candida and reporting candida non-albicans is not sufficient. Do a species level identification that I'm treating candida glabrata. So I have information that glabrata is already having resistance to so antifungal therapy. If you are reporting candida auris, it has different interpretation. So non-albicans is not sufficient, right? So even though the clinician has not requested, when we are sending a blood culture, we are not telling you that restrict your analysis to candida albicans and non-albicans. I am not giving you any information or instructions. It is you that you have to identify candida non-albicans as a tropicalis, glabrata, parasibosis, whatever it may be, right? So do a proper identification of the organism that will help clinicians to treat their patients. Again, the same thing, the normal flora, staph epidermidis, like we commonly say that it could be the contaminations, right? But when somebody is having a prosthesis or the central line, or patient has some graft or joint replacement, then this organism could be significant. So you cannot ignore that this is just contamination, right? So just to say a final word, the medical microbiologist can no longer remain isolated into the laboratory staring at the agar plates, right? They should collaborate extensively with the clinicians to provide optimum patient care and control antimicrobial resistance, because you can play an extremely extraordinary role to control antimicrobial resistance. And there is no time to waste. You have to act very fast. And the last word, don't work for the money. The money will automatically come if you work for the patients. Thank you very much.
Thank you, sir, for very informative lecture. I'm sure this lecture will be like a bridge between you and us. We can have a couple of questions from the audience if the time permits.
I don't have any question, but I want to share one incident happened with sir. Maybe he is not aware also. Before, just when the Candida auris is isolating our region, that was some what we can say, that was very much dangerous, that the whole talking is happening in entire region. So at that time I have isolated one auris at our hospital in Rajkot, and I have changed to Candida some other than auris, tropicalis or something, and I gave a report. So after 1 week I got call from the sir student that have you changed that Candida auris to Candida tropicalis? So I can say maybe he is knowing more microbiology than many of our microbiologists. Thank you, sir.
Really, Atul, it needs to be a clinico-microbiological related affairs all the through, whether it is hospitals or private practice. I totally agree with you, because I'm sharing my experience with cancer patients over the period of 30 years, that initially I was looking into cryptococcus because there were a lot of pigeons around and immunocompromised patients. And I was
also looking into aspergillus, which is also another agent to cause infections. But it was always candida, 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 and candida. And then we shifted from non-albicans to albicans. And then within that, we had a rigorous training in Chandigarh, wherein we looked into different types of candida glabrata. Like what you shared is really, really, very important for the patient, that they are antifungal resistant. So really, I'm so much with you for this topic. Thank you so much.
Thank you.
Good morning, sir. As you mentioned the role of microbiologist in helping the clinicians, I would like to say that we at Karamsad report all our culture reports with clinical correlation only. We report all the MRSs, ESBL, MCs, MDROs with all the footnotes related to that, what to give, what not to give, what should be the vancomycin, MIC, and how you can change your treatment. So all types of advices also we have started. So we had Vitec since 2012, and then from 2016 we started reporting MICs along with breakpoints and how to interpret those breakpoints along with your MICs, how to select the best treatment out of the susceptible drug, looking at the MICs and PKPDs also. So we have started that, and last year we attended Chikmar workshop. Dr. Ketan is here, so I would like to thank Shastri sir and Ketan also, because they were the instrumental in the shaping our minds. So after attending that workshop, we started reporting on Sundays and holidays, all cultural reports, along with clinical correlation and all AMSP advice that he spoke about. We have started taking baby steps towards that. So we are very happy that we are able to help our clinicians, and all of our culture reports are discussed with clinicians that this is doing and this is sensitive, or critical alerts are intermediate. So I think it is the right time that we should change our mind from just lab-based to the hospital-based, helping our clinicians to take care of the culture reports, because we are the ones who can change their minds how microbiology can contribute in patients' treatment and management. So thank you, sir.
Thank you for sharing your experience.
Sir, one question. Different institute clinicians have different expectations, specifically for the molds, fungi molds, sensitivity. Sir, what your institute, or as a consequence, your expectations regarding sensitivity of Aspergilli or mucor or anything else, or you are expecting something more extensively from the microbiologist?
Yes, so I think this is a very important concerns for clinicians, especially those who are in infectious disease practice. Apart from the yeast susceptibility, I think mold in vitro drug susceptibility also is very important. The reason is that if I'm talking about the aspergillus, the fumigators and the flavors, I mean, the incidence of rising resistance is very common. The fumigators resistance of the azole is common, and the flavors we know that amphotericin, MIC is pricking up and it's going to be very high. So the mold in vitro drug susceptibility is very important. And when we are talking about the mucorales species, we know that there are several subspecies of the mucormycosis which produces clinical infections, from Homothelicus to the Rhizopus erizus to, Syncyphilus, from many different species. And we know that the in vitro drug susceptibility of all the mucorales species is different. It's not same that amphotericin is going to work for all the mucorales species, right? So if you want to fine-tune your antifungal therapy, even if the microbiologist is reporting the mucor species isolated, I think, I have not touched upon this. I am not satisfied with the report that mucor species isolated. I need more information, which mucor species, right? That is very important. So you need to go for mucorales species, the identification, and that will also help me, even if I am not getting in vitro drug susceptibility testing, that will help me in selecting appropriate antifungal therapy for that mucormycosis, right?
Thank you, sir, for enlightening us.
Sir, I would like your input on the fact that step reporting, like for example, sometimes, especially in fungal diagnostics, sometimes speciation of Candida may take place a 1 day or 2 day of gap. So what's your take on stage reporting? Like the first report released that Candida species ID awaited, so subsequently in 24 or 48 hours followed by a candidate proper species or hyaline fungi grown in culture, ID awaited, and subsequently in few days, 1 or 2 days, 3 days, 4 days, we reported aspergillus. So this step reporting, multiple reporting at stages. What's your take on
This is very important. So I mean, this is how like we expect. It's not that from the day one you are going to get all the detailed species identification, drug susceptibility. So day one, when the blood culture flags and you are reporting that the yeast is identified on the blood culture bottle, so we can start appropriate antifungal therapy according to the yeast. And later on, like after 24 to 48 hours, when you are giving additional information that you are now looking at trichosporon, it is not a candida. So obviously we are going to change antifungal therapy to trichosporon. And if it is a candida species and now you are giving us a species which is glabrata or auris or some other thing, paracellosis, then again we may do a fine tuning of our antifungal therapy. So stage reporting is very important and we expect that, I mean, it should be done. So my point is not to, I mean, stop at reporting fungus or the yeast or the candida isolated from the blood. I also expect that subsequent, the further workup on the isolate should be done from the microbiologist and they should report additional reporting to the clinician, which can help clinicians to do a fine tuning.
Thank you, sir. I guess.
Fulfilling the expectations of a clinician, and that is going to justify the task. But I just want to ask you, sir, are there certain opportunities where clinicians do talk about the expectations of laboratory from them?
Are there?
Because that is a big challenge for us, for people who want to really contribute to clinical side. We don't get the kind of support we look forward to, starting from information about the correct sample which is being sent to laboratory. So how do we fill that gap? So many expectations are there from the laboratory person, but do you talk about fulfilling the expectations of lab?
Yes, so I always, whenever I mean, talk to my clinical the subgroups, we always discuss, if you are not sending a good sample which can be analyzed well, you are not going to get a correct results. So if you want a good inputs from a laboratory, provide them appropriate and best sample which can give you a good interpretable results and which can help in the clinical management of the patient. But I think I'm slowly, like the microbiology, when I was doing my MD medicine, there was a very, I mean, in Ahmedabad city, I think there were only 2 or 3 microbiologists they were practicing. So most of our, the selection of antibiotic was empirical, looking at the textbook recommendation that this is community acquired pneumonia, so give this antibiotic. It was never culture based. So most of our, the training, like we do not have any great exposures to the microbiologists, but over a period of, I think last more than 2 decades, the microbiology specialty has grown and now it is very well recognized into the clinicians, clinical field also. So I think, I mean, this problem is going to be resolved soon because now the clinicians also understand that what is the role of microbiology. They are not just
So that
the,
they have to
the
be
people
thankful.
sitting into the lab looking at the agar plates. I mean, you have to, I mean, talk to them.
So that for that we are thankful to the practices that are being adopted by the clinicians of rampant use of antimicrobials, and that has resulted in so much of AMR resistance that we are valued more, and the emergence of so many diseases. So it's a opportunity that I would request that, sir, whenever there is some clinical conference, do invite laboratory persons so that they can also share their concerns, because this is one of important area
Absolutely.
to complete. Thank you, sir.
Person. But this is the right time for teaching institute. We will start the clinical practice with our consultant. And so in this basis, we can do clinical microbiological correlation. We can bidirectional communication. We can also guide our clinician for antimicrobial patterns. We can also establish in our hospital antimicrobial stewardship program and everything. So we can guide our consultant also. Thank you very much.
Okay, ma'am. Now I'd like to ask Dr. Mansi Shah, ma'am, to felicitate, sir. May I now invite Dr. Sarita Gaonkar, ma'am, to felicitate our chairpersons, please. results of the microbiology quiz that we had is out, but we'll declare it after the panel discussion. We have a classroom scene right now, and I am that teacher, the one who said कहना क्या चाहते हो. Right. So what is CBME?
CBME means competency based learning. इंडियन मेडिकल ग्रेजुएट को क्या क्या आना चाहिए, कैसे करना चाहिए, कब करना चाहिए, सभी चीज.
अरे CBME की डेफिनेशन क्या है? चतुर तुम बताओ.
CBME is an outcome-based approach to design, implement, and implementation of the education system, as well as to assess the learners across the continuum using various competencies.
Excellent.
मैंने भी तो वही कहा था आसान शब्दों में.
ठीक है, वो भी देख लेंगे. The next panel discussion will enlighten us regarding the CBME in detail, and I request Dr. Urvesh Shah sir, moderator of the session, to join us on the stage, please. Dr. Urvesh Shah sir is one of the most dynamic microbiologists the Gujarat has at this time. He is professor in head department of microbiology at GCS Medical College Ahmedabad, and he has been a face of microbiology for media during the COVID pandemic. We all know him very well. He is also an honorary secretary at Ahmedabad Medical Association. Now I'd like to invite our panelists, Dr. Suman Singh madam. She is a professor at Karamsad Medical College. Ma'am, may we have you on stage, please? Dr. Sonia Balve madam. She is a professor at Baroda Medical College. Good morning. Welcome ma'am, good morning. Dr. Atit Shah sir, he is an associate professor at NHL Medical College Ahmedabad. I'd like to correct my announcement regarding Dr. Sonia ma'am. She is an associate professor at Baroda Medical College. Pardon me for that. Dr. Meena Kadam madam, professor and head at Narendra Modi Medical College, Maninagar, Ahmedabad. Good morning ma'am, welcome. Dr. Viral Shah, he is a consultant microbiologist at Unipath Laboratory, Ahmedabad. Welcome Dr. Viral, good morning.
Thank you very much. How was the conference since yesterday? I think you have a good taste of the microbiology subject. All the tools of the microbiology were covered, and at the end, what the Atul Patel sir said, that what the clinicians are expecting from you. દરેક માઇક્રોબાયોલોજીમાં તમે જેટલું ભણો છો એનો એક જે નિચોડ કાઢીને આપવાનો છે એની વાત સારું કરી. So in the last lecture we have learned what is expected from the teachings. What we did the MD in microbiology and we are doing a clinical microbiology practice. That is the clinician's expectations. And as Jayashree madam rightly said, that this is the message that we teachers, PG teachers, need to take how our PGs shall now work and learn. Our next panel discussion is somewhat in contrast to that. That is regarding the UG. That is again the learning process for our teachers, how we have to teach the UGs. And at the same time, this also reflects that what the microbiologists expect from a medical graduate, expect from the clinician. So what we are expecting from the clinician, that we will be getting only if we are going to teach them. If we are not going to teach them right now, we have to teach afterwards. Otherwise, as Suman Singh had said, we the microbiologists should move around the different conferences of the clinicians to teach them. So whatever we have platform right now, we can teach the medical graduates. And for that, CBME in medical microbiology was implemented. But we all have experienced the difficulties, right? So today's session is just to discuss over it and to take important for you. Believe me, this is for you. અમે બધા માસ્ટર થઈ ગયા, સેટ થઈ ગયા છે. જે પ્રાઇવેટ ચાલે છે બધાને સારું પ્રાઇવેટ ચાલે છે, વાંધો નથી. But this is for you. That is for your future. And for that we have selected eminent panelists from I think different specialty. When I am talking about Dr. Veena Madam, she is when I joined MD microbiology, she was in charge of the UG teaching. Bharti Madam જ્યારે HOD હતા ત્યારે વિજય મેડિકલ કોલેજમાં Veena Madam UG teaching માં in charge હતા. So she has knowledge, she has all experience regarding the UG teaching since then. Dr. Suman Singh Madam is very much instrumental in formulating this new CBME pattern, and very interesting, they are following this CBME pattern since last 10 to 12 years. So we can have a good input from her. Dr. Atish Shah, one of the most favorite faculty for the student. Student કદાચ બીજા કોઈ faculty પૂછ્યું તો સાંભળે પણ એનું સાંભળશે. એટલે એમને જે શું કહેવાનું છે, જો એમને ક્લિયર કટ હોય, બરાબર છે, તો એનો મેસેજ સરસ જશે. ડોક્ટર સોનિયા ગરવે મેડમ, genesis of thought process for today's this panel discussion. When she started discussing about the problems with the CBM in our microgroup, at that moment we start thinking about that. We have to keep this panel discussion. And Viral Shah will reflect, and that's why I will ask the first question to him. What is the current knowledge of clinicians? Before that, we must know why we are teaching the microbiology. What is important is the fundamental microbiology. It's very much clear. It's about infection, and infection. Right? We need to teach the graduates, medical graduates, about the infection. Diagnosing infection, preventing infection, treating infection. And for that we are teaching them microbiology. Right? One of the basic. Now, the question, why we needed to change in previous teaching methods? And that was the reason why the CBME was developed and circulated by the NMC, and we started. The question is more for the viewer is what you are thinking, because you are experiencing a lot with the clinicians. Let me introduce again. He is working as a microbiologist in the longest chain of laboratory, Unipath laboratory, and he has faced lots many problems while communicating with the clinicians. So he might be the good person can answer what is the present clinicians mindset, right? Even though already in discussion what we have discussed, the many clinicians are, madam, many clinicians are, they are toppers in their fields, good cardiologists, good orthopedic surgeons, they are topmost doctors. But what are the problem with them also? I'm not talking about only the routine physicians, even the topmost doctors. What are the problem with them also when they are dealing with the infection treatment, prevention, and diagnosis? Forget about the Atul Patel sir. Atul Patel sir is having knowledge even more than us. He is a PhD in microbiology. એટલે આપણે એમના એવા જેવા ડોક્ટરની વાત નથી કરતા બધાની. So Viral.
According to me, the Indian health sector is where the patients goes. I think 1% patient goes to the corporate hospitals, where almost majority of things are done ideally, like they have a good setups and all. But 99% patients are going to individual hospitals with standalone doctors like physicians, surgeons, who have their private clinics, and 99% surgeries and all the things will happen in private. So I am talking about this 99% where Indian patient goes. And the present clinicians situations and conditions of their mindsets, especially for the microbiology diseases, which we are which we have to deal with them regarding the microbiology, like when to send suppose there is a case of some infection, so they start and then they think regarding what now and in between if the patient responds to that antibiotics, they even don't bother to interpret the report, and suddenly the patient respond within 2 days, they suddenly stop and patient got discharged, and after 48 hours our culture report delivered at their office, and they just on the counter of the reception, and patient is well. After 5 days patient again come with same complaint that discharge again started. So these are the practical problems which we are facing, that when to send the cultures. Now second point, which type of sample should be sent, like suppose urine culture, so they are sending urine sample from Eurobank. They tell only the nursing staff that we send this urine sample, collect from nursing, collect from Eurobank and send to the lab. So when we receive the sample, we ask for the sample collection, how send this, how we collect the sample. They just say that we had collected from Eurobank and sent to you. So we have to educate them regarding this culture collection methods also. Sometimes we are receiving urine tips or catheter tips culture. So ideally it should not be collected even though they are sending, but then we have to educate again and again. So these are the practical aspects where which we are dealing in our day-to-day life still. And I'm talking about this 99% cases which are still treated in the nursing homes.
So definitely one is an approach for diagnosis infection.
Yes, 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 yes. Still, TB Gold is the for their TB Gold is the confirmatory test for tuberculosis. Still, majority of doctors are writing first test for tuberculosis diagnosis is TB Gold. So we have to educate them that TB Gold is not a confirmatory test for the tuberculosis.
So as you say, there was a problem with them for approach for the diagnosis, right? Diagnosis of any infectious cases, suspected infection.
So they know regarding the pathology test, when to send this test, but they don't know regarding the microbiological test, when to send and how to send. And for us, sample collection and transportation is the heart of microbiology. Our results are depend on the collection and transportation. So this is very important that we have to educate regarding this.
Again, just would like to have some brief on this point also, because what I am also observing, the knowledge and the skills of the clinician for the management of infectious disease. What he told about the problem with the diagnosis of the infectious disease, and what is the problem right now for the management of the infectious disease, that one apple keep doctor away. If it is not keeping away, then take 2 apple. Right? અત્યારે ડોક્ટર એ જ કરે છે ને, આ એન્ટીબાયોટિક લો નથી મળતી, લો આ બીજી એન્ટીબાયોટિક લો. So there is a problem with the antibiotic. What is your observation?
Same observation. Suppose there is some viral infections are going on, and if we observe, if we study the data from one doctor's OPD, how many patients are prescribed cefixime? So you find that out of 10 viral infection cases, 7 to 8% are prescribed cefixime antibiotic. And then you study another, that how long they take the antibiotic. Majority of patients take that antibiotic for 2 to 3 days. And then suddenly antibiotic stops. So these are the problems in private practice, where doctors are practicing standalone, not in corporate hospitals, where all the things are happening perfectly. So this is the commonest problem which we observed. Second, regarding the interpretation of the sensitivity reports, there are 2 methods, right? Disk diffusion and MIC based testing. But no any private clinician knows that what is the importance of MIC. MIC is very critical for the dose adjustment and dose change. And and for the selection of the antibiotic, which antibiotic will be the best among all the sensitive animals. So we have to educate regarding this MIC. What is the importance of MIC? What is MIC based sensitivity selection of antibiotic, and then switch over from broad spectrum to narrow spectrum antibiotic according to the sensitivity report. So sometimes we observe that if there is a wound infection and doctor started vancomycin or linezolid and the bug is isolated as Klebsiella. They don't know regarding that this vancomycin will not cover the Klebsiella. Still they are going with the vancomycin and then they are adding another antibiotic for gram-negative bacteria.
Yes, so these are some common problems, right? Starting the antibiotic without looking at the spectrum. As he said, the cefixime for the viral or even upper respiratory bacterial infections, pyogenic skin infection, they start with the cefixime. બરાબર છે? એટલે આ પણ એક બહુ common problem છે. Right? So, anything will you like to add?
We are giving a report based on MIC and we interpret whether it is a sensitive or resistant. Now our interpretation of report is basically based on the breakpoints, right? We all agree that we interpret based on the breakpoints whether it is sensitive or resistant. Now in the CLSI document, this is something which I added. Still we are not practicing in Ahmedabad, or I have not seen even across India. Whether because these breakpoints are basically generated from a fixed drug dosage form. So whether we require mentioning that these breakpoints are derived from this dosage, suppose meropenem 2 gram 8 hourly, and based on these breakpoints, we derive the MIC and we interpret. So if you want your patients to be treated in a sensitive parameter, you have to give meropenem 2 gram 8 hourly at least, because these breakpoints are derived from this. This is the any additional thing which we are not doing.
Yes, definitely. But Viral and Apit, to both of you, I would like to say, we need to meet the medical graduates. So I think these things should be left for us. And for that, what I need to give the message to our medical graduates, that you just talk with the microbiologist and listen to microbiologists. So that is the required, and conclusion also, that is the requirement for the teaching, the clinician, the medical graduates બહાર નીકળેલો કયા કેસમાં માઇક્રોબાયોલોજિસ્ટને સાંભળે. રિસેન્ટ એક એક્ઝામ્પલ, એટલે ગઈકાલ રાતનું જ એક્ઝામ્પલ છે કે મદુરા માઇકોસિસના કેસની અંદર હિસ્ટોપેથોલોજીકલ સેમ્પલ મોકલ્યું, ફંગલ ઇન્ફેક્શન હિસ્ટોપેથોમાં ડાયગ્નોસિસ, પછી ડોક્ટરને ક્લિક થયું કે ફંગસ આવ્યું, ઓળખીતો હતો ડોક્ટર, એટલે ફોન કર્યો કે આ ફંગસ આવ્યું છે, હવે આ બ્લોક છે, એમાંથી કલ્ચરથી આઈડેન્ટિફિકેશન થશે. એકચ્યુઅલી એને ફંગસ મગજમાં આવ્યું ત્યારે એને માઇક્રોને કોન્ટેક્ટ કર્યો, કારણ કે જે પણ ફંગસ છે એ માઇક્રોબાયોલજીમાં ભણે છે, બરાબર. મેજોરોફિટ જો મગજમાં આવે, મેજોરોફિટ જો ત્યારે માઇક્રોબાયોલજી કોન્ટેક્ટ કરવો જોઈએ, રાઈટ, કારણ કે એ મેજોરોફિટ સર્જરીમાં ભણે છે. મદુરા ફૂડની ફંગસ માઇક્રોબાયોલોજીમાં ભણે છે, મદુરા ફૂડ સર્જરીમાં ભણે છે, એટલે એ સર્જરીની અંદર જે બુકમાં લખ્યું એ પ્રમાણે પ્રોટોકોલ ફોલો કરે છે. સો what will discuss on that?
Still we received the requisition like one sample is received and in that prescription that aerobic culture, anaerobic culture, fungal culture, all the tests were written. But the sample is in formalin and only one
So I
sample was
think the major problem is the student is not really well trained to collect the samples properly and make report interpretation. Now we have to deal with the...
So, yes, madam, that is the thing. I am just coming to the conclusion to the what Viral said. The current approach of the clinician for management of the infectious disease, I am moving very fast now because I think we will have a short of the time. There's an irrational approach of the infection management. Either they are doing no investigation, over investigation, or inappropriate use of investigation, what they are saying, and inadvertent use of the antibiotic. This is the major problem, right? And second is the less importance to the infection prevention practice and misconception regarding the prevention methods. These are the current problem. Current aptitude of clinician for management of infectious disease is a poor concept of the application and interpretation of laboratory investigations, what right now we were discussing, and no systemic approach for antibiotic therapy, how to select the antibiotic. These two are the major problem with the clinicians. Why these are the problems? Because there is a poor understanding of the infection mechanism that we have to accept. There is a poor understanding of the infection mechanism. That is the reason why you are getting such kind of the samples and why you are observing such infections are treated randomly. And poor understanding of the infectious organisms. They don't have a concept about the commensals versus saprophytics versus pathogens. Whenever we start reporting the Klebsiella in endotracheal tube, they will treat. If we will report that, they will treat. Right? Colonization versus contaminations, આવો કોઈ concept જ નથી. આવા જે 5-6 અતુલ પટેલ સર જેવા 5-6 ક્લિનિશિયનને છોડી દો, બાકી કોઈ concept જ નથી. Right? What actually want the approach for the infection management expectation from the medical graduate? What actually we want? છોકરાઓ MBBS ભણી અને કોઈ પણ ફિલ્ડમાં જાય અને બહાર નીકળીને જ્યારે એમની સામે ઇન્ફેક્શનનો કેસ આવે ત્યારે at that time the evaluation of the infectionનો કેસ આવે ત્યારે એમને ઇન્ફેક્શનનો ઇવાલ્યુએશન કરતા આવડવું જોઈએ, ઇન્ફેક્શિયસ ઓર્ગેનિઝમ્સનું ઇવાલ્યુએશન કરતા આવડવું જોઈએ, ઇન્ફેક્શનનું મેનેજમેન્ટ કરતા આવડવું જોઈએ, ઇન્ફેક્શન ઓર્ગેનિઝમનું મેનેજમેન્ટ કરતા આવડવું જોઈએ. That's it. I think everyone is agree for that, madam. ઇન્ફેક્શનનો કેસ આવે એટલે એમને આ 4 વસ્તુ આવડવી જોઈએ. ઇન્ફેક્શનનો ઇવાલ્યુએશન આવડવું જોઈએ, ઇન્ફેક્શિયસ ઓર્ગેનિઝમનું ઇવાલ્યુએશન આવડવું જોઈએ, ઇન્ફેક્શનનું મેનેજમેન્ટ આવડવું અને ઇન્ફેક્શિયસ ઓર્ગેનિઝમનું મેનેજમેન્ટ આવડવું જોઈએ. So that what we are expecting from the medical graduate. But what was the system of teaching subject microbiology? We were teaching the medical important microorganisms, immunology. આ હું વાત કરું છું CBME પહેલા. Right? We were teaching the medical important microorganisms under this much headings, morphology થી માંડીને ઘણા બધા headings હતા. So what was the problem with this methodology, madam? Why we have to switch over to the CBME?
The problem area is not restricted only to the subject of microbiology. The problem area has been expanding across all 22 specialties, and that has led to a very focused effort by a large number of people in education considered as expert. The problem that we are facing as microbiologists is, lots of new infections coming, the clinicians not being able to take decisions on the right sample that needs to be collected, the time that needs to be taken care of, the type of antimicrobial choices that need to be made. So subject had got specific problems, and the graduates that we are preparing are not capable of really understanding the application of all the topics that Urvesh said are being taught to them. So we are teaching students staphylococci, we are teaching the morphology, we are teaching coagulase test, catalase test, we are giving certain medias, certain biochemical reactions, the toxins produced, the disease produced. But what happens when a patient with skin infection comes? He does not know whether patient with skin infection, he has to keep in mind staphylococci also. He has to keep in mind streptococci also. He has to keep in mind fungal also. So when you look at the way a patient is being trained, was being trained before 2018, till 2018 you can say, because the curriculum came from 2019. So till 2018 the student was being taught microbes. The student was not being taught the application of microbes in a clinical context. So patient was never important for microbiologist. The microbe was definitely very important. So we gave all our due attention to understanding in detail about their life cycles, about their pathogenesis. But when I see a patient of fever, I don't know what's happening. I get confused. What has to be kept in mind when a patient with fever comes? Is it going to be infectious? It is going to be non-infectious? It is going to be autoimmune? Is it going to be cancer? I don't know, because I have never been trained like that. So the isolation, the way the student has been trained till now is in complete isolation. I had a fear of microbiology because I got confused which color green is positive or whether blue is positive. The TSI with 3 color created a terror in my mind कि उसमें positive लिखो, negative लिखो, equal
microbiology was being taught, plus there was no importance of communication. Now we have realized the way we have introduced the session by Dr. Atul, that is simply talking about enhancing the communication and identifying the opportunities of communication in laboratory and clinical care. So now the need for enhancing communication, the need for maintaining confidentiality, the need for respecting a patient sample, that was never realized before 2018. But the kind of problems we saw in community, the kind of results we saw in patient care, they all were the triggers which led to the change. And I think we all perceive that it is a positive change, because now we are making patient as the center of learning everything.
Is the definition of microbiology for undergraduate. I am talking about undergraduate, not postgraduate. What is the need for syndromic approach for undergraduate? They should know. They are there, no? Preventive work. Yes, sir. Overview for parasitic infection. What is it? Overview.
Who is, sir, do you think the clinicians before 2018 were, sir, we are not talking, sir, success or failure, how do I define? So
By conducting exams in Viva.
it all depends, sir. When we talk about change, no, let me just finish. When we talk about any change, then that is going to create lots of frustrations and emotionally diverse responses in any community. Yes, so it is going to persist.
Sir,
Who?
madam,
So
madam,
that
this is-
means, who is frustrated, sir?
this is actually, sir, what? Nee.
Sir, it is not about acceptance.
Madam, what sir is saying is 100% truth. Right now, the teaching in second MBBS microbiology is complete mashup, right?
Okay.
Actually, with the purpose, what we have started the CBME,
No.
why we have not achieved, we have to work for that. What we and I think madam will be agree with me that now this is not a point to just going back to the same teaching pattern, but we may find out some more better way to have
नहीं उर्वेश,
achieve
just let
achieve the
me,
goals.
नहीं सर, पहले तो ये बात हमारी क्लियर होनी चाहिए कि अगर हम फ्रस्ट्रेटेड फील कर रहे हैं और हम ये देखते हैं कि बच्चे भी फ्रस्ट्रेटेड फील कर रहे हैं, फाइंड आउट द कंक्रीट एविडेंसेस एंड रीजंस फॉर फ्रस्ट्रेशन. So we have to, so probably, सर पहली बात, सर, abrupt response is natural. Things are going to happen slowly. Yeah.
I want to add something.
Very slowly.
ઓકે સર આ બધાના જ પોઈન્ટ્સ ડોક્ટર આજે વિગત સાહેબ તમે કહો છો ને આ બાકીના 3 સાહેબો અને મેડમ એના માટે સાહેબનો એક મેસેજ ક્લિયર કટ છે નહીં સાહેબનો ક્લિયર કટ નહીં સર બીકોઝ વી આર વેઇટિંગ ફોર ધેર ઓપોર્ચ્યુનિટી
See, probably.
ક્લિયર કટ એક મેસેજ છે. We will have input from madam. We will come to that.
Okay.
Later on.
No problem,
But
please.
just as what madam has highlighted, that is also very important to understand. Definitely we will speak, sir.
I want to add something.
Oh, yes.
Why we need a new curriculum? That was the new CBME. The reason was that our graduate medical regulations were date back 1998. Until 20 years, there was no regulations, no change was there. So in 2018, we required to revise the curriculum. It's okay that we require a revised curriculum, but what happens in most of the other branches, the curriculum has changed little bit. But in our microbiology fraternity, it has changed 360 degree. Traditionally, we were teaching organism-based approach. Now we are teaching a system-based approach. Actually, what I personally feel, the curriculum has been adopted from the US schools. I have gone through the Harvard Medical School website. The entire curriculum has been brought. The ADCOM competencies, then early clinical exposure, then electives. These all are the modules of a Harvard Medical School. So the curriculum has been adopted from there. Now, what happens in a US medical school? A student will enter into the US medical school after 4 years of Bachelor of Science. In this Bachelor of Science, he learns basic, they take the various subjects, and basically biology or microbiology, they take as a major subject. Most of the US medical students, US graduate students. So they basically learn organism approach during their 4 years Bachelor of Science, BS. And after that, they enter into medical school. So they just want to apply the clinical knowledge of the things which we have learned. Now, this is not happening in our students are not learned microbiology during their school days or previously. So this is the the problem is here that we have directly jumped to the organism from organism-based approach. We have directly jumped to the system-based approach.
Madam, what I suggest to you, because we will have lots of the questions. You just write down all that, and finally you just answer that.
Okay, let the question be out.
Finish all the questions.
Yes, let everyone.
Yes, first we'll go with all of their concern. That is also important, madam. Actually, what madam said, that what we were studying, infectious organism. Staphylococcus, streptococcus, pneumococcus of the bacteria બનતા હતા. બરાબર છે? અને એ જ ટીચિંગમાં આપણે ઓર્ગેનિઝમના ચેપ્ટર હતા. Definitely. Yes. Yes, already mentioned.
Yes, sir.
Sir, that is mentioned here. But our chapter name was infectious organisms. We were studying the characteristics of the organisms. We were studying the pathogenesis. We were studying the clinical infections, evaluation of the infections, laboratory diagnosis, and up to the treatment and prevention. Right? But with that approach, what we were finding, we were studying the organisms with the characteristic and where we are failing, the evaluation of infection. જ્યારે તમે કોઈ પણ સ્ટુડન્ટને, હું હમણાં છે ને એક જગ્યાએ એક્ઝામ લેવા ગયો તો મેં સ્ટુડન્ટને પૂછ્યું કે સ્કિન સોફ્ટ ટિશ્યુ ઇન્ફેક્શન છે એનું લેબોરેટરી ડાયગ્નોસિસ, તો હું વોઝ નોટ અવેર કે શું કરવું છે. કદાચ મેશર તો એટલા માટે જ, પણ મેં એને તરત પૂછ્યું કે સ્ટેફેલોકોકસનું લેબ ડાયગ્નોસિસ, તો બોલવા માંડ્યો કે ન્યુટ્રન્ટ અગરની અંદર આવો કલર ને બીટા ઇમ્યુલેસિસ. એટલે મેં પૂછ્યું ત્યાં એક્ઝામ કે હવે આ સ્ટેફનું મને કે અમે તો નવી મેથડ એડપ્ટ જ નથી કરી, જૂના પ્રમાણે જ ભણાવીએ છીએ. જૂના પ્રમાણેનો જૂના પ્રમાણમાં આ પ્રોબ્લેમ છે કે સ્ટુડન્ટને સ્ટેફેલોકોકસનું ઇન્ફેક્શનનું ડાયગ્નોસિસ ખબર છે, સ્કિન સોફ્ટ ટિશ્યુનું નથી ખબર. એની પાસે પેશન્ટ સ્ટેફેલોકોકસનું ઇન્ફેક્શન છે લઈને નથી આવવાનો, સ્કિન સોફ્ટ ટિશ્યુ ઇન્ફેક્શન લઈને આવવાનો છે. સો ઇવેલ્યુએશન ઓફ ઇન્ફેક્શન ઇઝ complete failure. It was complete failure, and that is the things what we are observing the our topmost doctor જે વિરય કહે છે ને, સારામાં સારા ડોક્ટર છે એમને ઇન્ફેક્શનનો ઇવેલ્યુએશન નથી ખબર.
Sir, we are teaching now staphylococci and streptococci in skin infection, in respiratory, in cardiovascular, in all.
Yes.
So what is the
નહીં મેડમ બેઝિક પ્રોબ્લેમ બધો જે છે જે સાહેબે કીધું એ પણ એક બહુ મેજર પ્રોબ્લેમ છે, ટાઈમ રિડ્યુસ કરી નાખ્યો છે. પણ મેડમ હું આના પર પણ આવીશ, એન્ડ જસ્ટ યુ સ્પીક ઓફ ધોઝ થિંગ્સ ઓલ ધેટ ટાઈમ.
સર બીજું
પણ એની સાથે છે ને બીજું એ છે કે ઇન્ફેક્શનના મેનેજમેન્ટમાં બેક્ટેરિયાનું મેનેજમેન્ટ એને ખબર છે કેવી રીતે કરવાનું, પણ ઇન્ફેક્શનનું મેનેજમેન્ટ નથી ખબર. એટલે ઇન્ફેક્શનના મેનેજમેન્ટનો એપ્રોચ જ નથી એમની પાસે. સ્પેક્ટ્રમ વિચારવાનું, એન્ટીબાયોટિક સાથે કોરિલેટ કરવાનું. હા, આ રીઝન હતું કે આપણે ચેન્જ કરવો પડ્યો. બરાબર, પછી ચેન્જ કર્યા પછી પ્રોબ્લેમ્સ થયા એ અલગ ઇસ્યુઝ છે, પણ આ રીઝન હતું કે આપણે ઓર્ગેનિઝમ એપ્રોચ હતો અને એને કારણે એની પાસે ઇન્ફેક્શન ઇવોલ્યુશન અને ઇન્ફેક્શન મેનેજમેન્ટના કોઈ કન્સેપ્ટ જ નતા અને એની અંદર બધું જ આવી ગયું ઇન્ફેક્શન ઇવેલ્યુએશન્સ માટેના સેમ્પલ કલેક્શન થી માંડી અને એન્ટીબાયોટિકના રિપોર્ટિંગનું interpretation and choice of the empirical antibiotic. This was the problem.
Right now, you see that there are a lot of hospitals, individual hospitals are opening. They build their hospital OTs. But you see the setup, you will find that there is lack of hospital infection control practices in individual standalone hospitals. And there are a lot of infections happening. Even there are in small hospitals,
I think
TKR is
we are
going
talking
on.
about MBBS curriculum.
No, sir. So this is a basic concept of hospital
Actually,
infection control.
MBBS.
Yes, મેડમ એના માટે આપણે ડેફિનેટલી આમાં આપણે થોટ પ્રોસેસ ઇમ્પ્લિમેન્ટ કરવાની જે છે અને મેડમ સુમનસિંહ મેડમ પણ એગ્રી થવું પડશે બરાબર છે વહેલા મોડા કરવી જ પડશે કઈક હું હા બસ આપણે એ જ કન્ક્લુઝન પર આવવાનું છે 2019માં જ્યારે આપણે કરી હતી ને અહીંયા આગળ કોન્ક્લેવ અહીંયા જ થઈ હતી બરાબર અને તે વખતે આપણે આ ટોપિક ડિસ્કસ કર્યો હતો કે સીબીએમઈ ઇમ્પ્લિમેન્ટ થવા જઈ રહ્યા છે અને એમાં શું શું લાવવાના છે પોઈન્ટ્સ અને એની અંદર આપણે ઘણું બધું ડિસ્કસ કર્યું હતું બરાબર તો હાઉ ટુ ચેન્જ મેડમ સુમનસિંહનો ક્વેશ્ચન શું પોસ્ટપોન કરું છું પછી આન્સર આપશે છેલ્લે એમ જે કીધું એ પ્રમાણે ઇન્ફેક્શન બેઝ એપ્રોચ નતો બરાબર છે સો ઇન ન્યૂ સીબીએમઈ વોટ વી સ્ટાર્ટેડ અ કેસ ઓફ ઇન્ફેક્શન બરાબર આપણે ઇન્ફેક્શનનો કેસ છે અને ત્યાંથી એપ્રોચ શરૂ કર્યો પહેલા ઓર્ગેનિઝમથી હતો હવે ઇન્ફેક્શનના કેસથી યુટીઆઈ રેસ્પિરેટરી ઇન્ફેક્શન્સ એન્ડ ધેન વી કવરિંગ બોથ characteristics of the organism, responsible in organism, mechanism of infection, evaluation infection organism and management. અને એને કારણે આપણને શું કહ્યું કે evaluation of infection and evaluation of infectious organism and management of infection organisms આપણને એ જો પ્રોપરલી બને તો એના માટેનો આપણને એક એપ્રોચમાં કંઈક પોઝિટિવ ફાઇન્ડિંગ મળ્યું બરાબર છે પણ મેશઅપ ક્યાં થયું કે જે રિવર્સ ડાયરેક્શનમાં જે ટીચિંગ ગયું કે એ કેસ ઇન્ફેક્શન કરતા એને જે ઓર્ગેનિઝમ્સ રિસ્પોન્સિબલ માઇક્રો ઓર્ગેનિઝમ્સ ભણવાનું હતું એના જે કેરેક્ટરિસ્ટિક ભણવાના હતા અને એ જે રિવર્સ ડાયરેક્શનમાં ગયું ત્યાં આગળ કમ્પ્લીટ મેશઅપ થઈ ગયું એવું મારું માનવું છે હવે સોનિયા મેડમ એમ કહેશે
After long time. So what are the difficulties we are facing? See, I think everyone, from all of us, हमने सबने exam लिया recently. So you all passes through same feelings which I have. My college, that is Baroda Medical College, I think it is a dream college for undergraduate after BJ Medical. Student की choice होता है ये college. Great. So since last 28 years I am teaching there, but the graph is, there is gradual decline, phase of decline. We are in phase of decline, student performance wise. And Indian medical education system, it is one of the largest education system in the world, I think so. But we are producing doctors for India also, for our country, which is developing still. Still every year we have epidemic of cholera, hepatitis A, hepatitis C, every year. But we thought about USMLE students. Less than 5 or 10% students appear for other countries' exam. So pure, where is the flavor or essence of microbiology? उसका essence ही खो गया है. We lost our alignment. कहीं alignment ही नहीं है system. So first, for alignment, first we should know ना exact what is staphylococcus. Students say streptococcus aureus. 2 days. Cholera is a virus.
मैडम वो अभी मैं देखो टाइम्स ऑफ इंडिया में लास्ट
We should know.
हाँ मैं टाइम्स ऑफ इंडिया में लास्ट वीक एक पीडियाट्रिक एसोसिएशन के बोर्ड लर्निंग जो बहुत इंटेलिजेंट डॉक्टर था उनका आर्टिकल था उसमें भी उसने लिखा था कि स्कारलेट फीवर में रिस्पेक्टिव ऑर्गेनिज्म इज स्टेफाइलोकोकस पायोजेनस वो सबसे इंटेलिजेंट डॉक्टर उसने ही लिखा था
Organism. They should know.
In 1 year curriculum, there is absolute information overload. Student cannot sustain that. Because of that, when you ask them the clinical diagnosis or the lab diagnosis, they will all end up in a very beautiful word which is written as a Vitek 2 compact and a Malidor. So दोनों मतलब लिखते हैं, दोनों बोलते हैं.
આયન જે પેપર વાંચે એ પેપર વાંચે હોય કે ગમે તે હોય
બધામાં Malidor અને પેલું લખી દેવાનું અને જીનોમિક સિક્વેન્સિંગ.
Sunita, now that's problem with the student as well. Let me very much frank for that. આપણે કહીએ છીએ કે ટ્યુબરક્યુલોસિસ પૂછવાનું જ છે. ટ્યુબરક્યુલોસિસ
આપણે છોકરાઓને ક્લિયર કટ કહીએ છીએ કે ટ્યુબરક્લોસિસ તો પૂછાવાનું જ છે. તમે ભણો તો ટ્યુબરક્લોસિસના ક્વેશ્ચન છે પણ એની અંદર 70 થી 80% છોકરાઓ કશું લખી નથી શક્યા અને white ને લખે છે. સો ઇટ વોઝ નોટ અ પ્રોબ્લેમ. પરહાપ્સ એમને કદાચ વાંચી જ નથી શક્યા, વાંચવાનો ટાઈમ નથી મળ્યો, આ બધું જે છે એ પાછળ આવે છે. બરાબર. તો હું આ મેડમને કહું છું કે આ પ્રોબ્લેમ તો પહેલેથી છે.
No, sir. Individual bacteria, individual pathogens must be there. Overview of parasitic disease. What is it? Overview of viral diseases. What is it? All trematodes in one paragraph only. How come? They must know about amoebiasis in India. They should know about giardiasis. What is giardia? Small paragraph.
What I think what the difficulties. No, what the difficulties उसमें क्या क्या डिफिकल्टी आ रही है? जैसे कि आपको आप बता रहे हो कि ऑर्गेनिजम्स का नाम ही पता नहीं है उनको, क्योंकि हम इसको डिटेल में पढ़ाते नहीं हैं.
सर TSI साइट्रेट तो बहुत दूर की बात है, उन्हें ऑर्गेनिज्म का नाम ही नहीं पता. और व्हाट इज TSI? दे शुड नो TSI एंड साइट्रेट. व्हाई नॉट?
एक्चुअली तो प्रॉब्लम मैडम का जो है ना वो बहुत वैलिड प्रॉब्लम है.
Urvesh, I really want to know why should an undergraduate student know TSI and citrate? Tell me one application. No. Tell me one application of no. Why would he identify?
Madam, we all agree that students does not require to learn biochemical. In the era of Parekh and multitop, it's not required.
Parekh या multitop अगर नहीं है तो माइक्रोबायोलॉजी के पीजी स्टूडेंट का काम है यार. यूजी स्टूडेंट से क्यों एक्सपेक्ट कर रहे हो तुम?
We don't know.
Madam.
What is catalyst for this?
Madam, what I have already answered.
What is
DJ medical topper, madam, DJ medical topper, topmost pediatrician in times of India. He is writing special for child illness responsible for child fever. So this problem universal present since long.
They should know.
This is since long.
We are not clinician, huh? Medicine physician are there, no? Preventive medicine, they are there.
No, madam, Sonia, madam, very well accepted. We have concern.
General infection.
Madam, your concern is very well accepted.
Okay, one more example.
Please keep silence. Please keep silence. No, please don't talk with each other. આપણે મારી કન્ક્લુઝન આપણે જ બોલા છીએ કંઈક આવશે બહાર. બરાબર છે? એટલે તમે અંદર વાત ના કરો, પછી જલ્દી વખતે આપણે ભરપૂર વાત કરીશું. પણ આ જે એક્સપર્ટ છે અને એમના કન્સર્ન છે એ લોકો અહીંયા આપણી સ્ટેજ ઉપર છે. બરાબર. આપણે એમને સાંભળીએ. Sonia madam, take examples about.
What about anaerobes? If I ask any question about how will you suspect in OT कि भाई एनारोबिक इन्फेक्शन हो सकता है, तुम्हें कैसे पता चलेगा? जब उसको एनारोबिक इन्फेक्शन ऑर्गेनिज्म का ही नाम नहीं पता तो वो काय में कलेक्ट करेगा? उससे मेथड ऑफ कलेक्शन फॉर एनारोबिक पर वो सोच ही नहीं सकता. तो उसको पता ही नहीं कि एनारोबिक ऑर्गेनिज्म क्या है. आप बोलो तो अरे भाई कोएगुलेंस की इंपॉर्टेंस बैक्टीरिया के लिए है कि लैब के लिए है कि हमने लैब में डाल के कोएगुलेंस.
बेसिक मैडम मुझे कंसर्न है. आ तो लॉट ऑफ एग्जांपल बेसिक कंसर्न है કે છોકરાઓને બેક્ટેરિયા વિશે જ નથી ખબર પડતી. એમને યાદ નથી રહેતું કે કયા બેક્ટેરિયા શું છે. એ આ CVME આ એક પ્રોબ્લેમ ઇશ્યુ એરાઇઝ થયો છે. આ મેડમનો બેઝિક કન્સર્ન છે. પણ કોઈ પણ એક્ઝામ્પલ આપણે લઈએ તો વસ્તુ તો આ જ છે.
Nobody knows about virulence factor. What are the toxins? Which are responsible for producing disease? They should know. MBBS वाला प्रैक्टिस करता था पहले.
હવે ઠીક છે.
Okay.
મારો ક્વેશ્ચનમાં છે ને એ પણ છે કે મેડમનો કન્સર્ન એની સાથે તું પણ એગ્રી છે. બટ આઈ એમ ઓલ્સો એગ્રી ફોર ધેટ. આ ખરેખર સિસ્ટમ છે કે એનો મેનિફિકેશન પોસિબલ છે.
Okay. In year 2019, we faced two major challenges. One was a COVID-19 and second was a curriculum 19. Because the curriculum has been totally changed. Now it's based on competency, right? Now the competency, madam, I personally feel they are not defined. They are not framed properly. There are 54 competencies covering 8 major topics. Out of these 6 were systemics. Now I am just giving you one example. There is the one competency which is written that students should know the basics of infection control practices. That is the one competency. Now there is no definition, there is no clear-cut guidelines of what are the basics of infection control practices. Because if you go, there are books available like Sundar's infection control. There are 1,000, 2,000 page books are available for infection control practices. So there were no standards. There were no clear-cut which are the basic points. So what happens at that time, there were no books also available. The books which are we were using previously, and all the international books, either Conlan, Mahan or Levinson or Javed, they all have got the organism approach, right? There were no books. So what happens? The guiding principle becomes the launch of Apurva Sastry books. Dr. Apurva Sastry has wonderfully created a curriculum. Basically, I feel that curriculum has been devised by Apurva Sastry, not by the NMC, because he has given that these are the topics which has to be taught in the infection control practices. So, madam, what is that? The competencies are vaguely defined. See, in the respiratory infections, there are only 3 competencies. One is to know. The students should know what are the upper respiratory. There are 3 words which are given in all the competency. Students should know etiopathogenesis, clinical course, and laboratory diagnosis, the upper respiratory infection and lower respiratory infection. So that is the only one competency, and entire respiratory system is over. So if you want to write competency, you can also write single competency. Students should know the etiopathogenesis, clinical course, and that is all body infections. The task will be over. So, ma'am, so what is the competencies are not clearly defined, and because the competencies are not defined, we are not able to deliver the optimally. That is the main thing.
इन कॉम्पिटेंसी 1 and 2 आप बाद में बोले, जो इसका जो मेन कंसर्न है, वो कॉम्पिटेंसी 1 और 2 में बहुत ही कुछ पॉइंट्स में सब कुछ लिख दिया है. बाकी 3 onwards आपने बहुत लंबा सारा मैडम
writing the competency, they are writing in number 1, number 2, CBS, they have written GIT, then later on they are exhausted. So I just write operative sanitary system, urinary infection, and SCI. Instead of issues, one and two infection, and aerobic, only 3 competency. So what is this? So
I think what we discussed, it is possible if we can modify competency in some way. Elaborate the competency in some way. We can just first time with this methodology. Madam, હું કશું આપણા પ્રમાણ થતું નથી. પહેલા પણ જો જોતું હતું નથી મળતું, એને આ કોઈ તમારા નવા કરિક્યુલમમાં આપણે શું જતું રહ્યું? શું કહો છો તમે?
Actually, the CBME was implemented in 2019, and CBS kept more weight on the learner-centered teaching learning method like small group discussion and DOP. Okay, these things require larger number of faculties. So my first point, the first limitation is the number of faculty. We have less faculty. Not only mere presence of faculty, they should be trained. And they should be always ready to update themselves also. And that require the repeated facts. And that was not possible because of COVID-19 that occurring in 2020. Okay? And at that time, we are teaching the students online. So most of the competencies, it is difficult to teach online and to assess it. So, and also just teachers training is not possible. Though some training are carried out online as a faculty development program, but it is difficult to train them by online. So I think the less frequently arrangement of faculty development program, that is the second point, because faculty plays the key role in the effectively the acceptance of the CBME. And my third point is that there is drastic change of CBME curriculum from traditional curriculum. That should not be followed. Ideally, there should be some combined curriculum or or you can do some part of CBME curriculum and some part of traditional curriculum, as Dr. Vigarbhai told that the basic concepts of microbiology should be there, organism wise. So there should be part of CBME curriculum and part of traditional curriculum. My fourth point is shortage of time. The time frame given by the NMC, it is very difficult to complete, to teach and assess all the competency, all the core competency within this time frame. We are giving the time of 1 year, but do you know, get 1 year? I think only 7 months, 7 or 8 months. So it is difficult to teach all the competency and assess them. That is the fourth point. And maybe this, as the CBME was implemented in 2009, and immediately after that the COVID era has came. So there maybe we are in transient period. Students and also faculties are in transient period of accepting the CBME.
એટલે મેડમ શરૂઆતમાં એવું થયું કે 20-21માં છોકરાઓ સારા ના આવ્યા ને એટલે આપણે એવું માની કે ઓનલાઈન ટીચિંગના કારણે જ આવો પ્રોબ્લેમ થયો.
In 2024 also, the graph is same.
So finally, concluding with their all concern, લેવલ સર પણ જે કહે છે એમ આપણે કેસ ઓફ ઇન્ફેક્શનથી એપ્રોચ કરવાનું સ્ટાર્ટ કરવું. We can cover this spectrum. કદાચ એ લોકો એ વાંચવા નહીં આવે તો ભૂલી ગયા છે, પણ એટલીસ્ટ upper 3 portions તો ટોટલી વાઇપ આઉટ થઈ ગયા છે. Either they are not reading, they are not studying, કે પછી maybe કોઈ સબ્જેક્ટ માટે એમને કોઈ આવું ફિલિંગ્સ નથી રહ્યા. મેડમ, how to address these challenges?
See, personally for me there is no challenge. But what I say is, bigger the challenge, bigger the opportunity. So if you feel that it is a huge challenge for all of you, then it's a huge opportunity for most of you also. You can say whenever there is change, it is going to be a challenge. Another thing is, this change is not something which is made by us. This is a change which time has asked us to do. There are lots of drivers which have really forced us to change. And maybe we assume कि पथों में इतना change नहीं हुआ, माइक्रो में बहुत ज़्यादा drastic change हो गया, हो सकता है. Because the whole way of looking at organisms has been completely changed. Now we want the student to look at the patient and then identify the organism. पर मुझे ये समझ में नहीं, physicians are not teaching them microbiology. अगर physicians, no. So अभी मेरा turn है, अभी मुझे बोलने दे. So मेरी बात सुन लो मैम. मास्क लाके दो जरा.
मैडम वो भी अब बहुत उसके बाद बहुत बड़ा क्रैश आने वाला है. मैडम फिर आपने पूरा कर दिया.
Yes. So क्या बोल रही थी मैं? हाँ. So when you're talking about microbiology, पहली बात ये हमें भूल जाना पड़ेगा कि मैं बच्चे को माइक्रोबायोलॉजिस्ट बनाना चाहती हूँ. Post graduates are going to learn in and out of the microbes. It is their task to do everything in detail. Undergraduate student को क्या मालूम होना चाहिए एक ऑर्गेनिज्म के बारे में? उसको मालूम होना चाहिए कि ऑर्गेनिजम्स की कितनी टाइप होती हैं, ऑर्गेनिजम्स जो भी उनके डिफरेंट टाइप्स होते हैं, उनके क्या बिहेवियर्स और पैटर्न्स होते हैं, उनके क्या एपिडेमियोलॉजिकल कैरेक्टरिस्टिक्स होती हैं जो उनको एनवायरनमेंट में सरवाइव करने में, ट्रांसमिट करने में हेल्प करती हैं या अडेप्ट करने में हेल्प करती हैं। इन्फेक्शन की पैथोजेनेसिस के जो कंपोनेंट्स है कि भाई वो कैसे ट्रांसमिट होगा, पेशेंट में कैसे जाएगा, कितना टाइम, कहाँ से एंट्री होगी, कहाँ से एग्जिट होगी, कितना टाइम लगेगा, सो दैट ही नोस कि किस टाइम पे मुझे कौन सा सैंपल लेना चाहिए, उसका इंटरप्रिटेशन क्या निकालना चाहिए।
और जब हम सीबीएमई की बात करते हैं तो हमें ऐसा क्यों लगता है कि ओनली बिकॉज ऑफ सीबीएमई अ स्टूडेंट हैज नाउ स्टार्टेड हाइब्रिड कनेक्शन ऑफ बोथ स्टेफाइलोकोकस एंड पायोजेंस? Was the student not doing the mistakes before? And when we are talking about the level of student and not feeling satisfied कि बच्चा अब बिगड़ गया है and everything the credit goes to CBME, have you asked yourself what are the questions that are you asking? Every time, see, when you are teaching the traditional curriculum, most of the time you would ask cell wall की bacteria का diagram draw करो, उसकी morphology बताओ. Most common question asked from general microbiology, you draw and label a diagram of bacterial cell and elaborate the structures. हाँ, तो that is what we are, so that is what we are not supposed to do. Sir, so that is what. So, yes. सर मेरी बात एक सुन लिए, एक बार प्लीज मेरा चांस तो।
मैडम सर, दिस वाज जस्ट एन एग्जांपल, सवाल को पूछा ही चाहिए
ना,
वो तो हुई मान
नहीं पूछ
एग्जांपल।
सो अरे सर मेरी बात तो सुन लो सर, जब एक बार चांस दिया है तो बोलने दो। जो What I am saying is कि अभी हमें, अगर सबने BCME या CISP अटेंड किया होगा तो हमें मालूम है कि there is a way we want the student to progress, right? We have been focusing on nose level of the student. अभी मैं बच्चे से एक्सपेक्ट कर रही हूँ कि बच्चा डायग्राम ड्रॉ करे, ग्राम पॉजिटिव ग्राम नेगेटिव का, उसके स्ट्रक्चर्स बताए, मॉर्फोलॉजी बताए, बट हाउ इज दैट गोइंग टू बी एप्लीकेबल टू द स्टूडेंट? सो आई हैव टू टीच द सेम मॉर्फोलॉजी, I have to teach the same structure and their antigenic characteristic, but I have to ask them the question with a twist. I have to ask them that describe the significance of morphology of a bacteria in decision making or when making a choice of antibiotic.
That is the purpose of CBME.
So it is a small twist that we have to do. So when you are asking question, define, enlist the virulence factors of a particular organism. So you are asking the direct question. But when you tweak your question with a clinical presentation and say patient has presented with eruptions on the skin, then you have to ask why this patient is presenting with eruptions. What are the factors responsible for development of that? So you are teaching microbiology. So when you are,
but
सर मेरी बात सुन लो।
एक मिनट।
तो मैं ऐसा कह रही हूँ कि जब हम सीबीएमई की बात कर रहे हैं, हमें ऐसा क्यों लग रहा है कि हमारा माइक्रोबायोलॉजी जा रहा है? See, when you are starting, अरे सुन ले बहन, मैं example, I just want to say for example, CBME में competencies बहुत limited दी हैं, और वो एक पॉजिटिव पॉइंट है। वो एक पॉजिटिव पॉइंट इसलिए है क्योंकि भगवान ने हम सबको बहुत ही इंटेलिजेंट बनाया है। हम सब अपना अपना दिमाग यूज करके, हमें पता है कि अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन माने क्या। Why do you expect everything to come from higher up? अगर वो बोलते कि तुम स्ट्रेप्टोकोक को ही पढ़ाओ, तुम, when you talking about disease, when you're talking about disease, you know microorganism is not restricting to one location. So you cannot give specific organisms. You have to just specify the student should be able to diagnose the infections present in upper respiratory tract, and so you have, see, okay, so a patient, when you are teaching this competency, we have to design our lesson plans in the way it is going to be useful. So when I start upper respiratory tract infection, what am I going to teach? CBME में क्या पढ़ाऊंगी मैं? I want to know it from you, the teachers who were teaching traditionally, and now who wants to teach. अरे भाई बैक्टीरिया को बैक्टीरिया
पढ़ना तो है, पर किस तरह से पढ़ाना है उसके ऊपर हम थॉट कर रहे हैं।
नहीं, but you are not taking the importance of pathogen away. मैं ये बोल रही हूँ कि ये हमारा माइंडसेट हमें बदलना पड़ेगा। मैं पैथोजन का इंपॉर्टेंस कम नहीं कर रही हूँ। अगर मेरे पास अपर रेस्पिरेटरी ट्रैक्ट पेशेंट की पूरी ऑर्गेनिजम्स की कॉम्पिटेंसी डिलीवर करनी है, तो आई सिंपली स्टार्ट विद द क्लिनिकल सिनेरियो, बट दैट क्लिनिकल सिनेरियो वेरी क्विकली शिफ्ट्स टू द ऑर्गेनिज्म। अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन माने कौन से ऑर्गेनिज्म? So immediately you make a list of differentials, and when you make the list of differential, then you choose which are the most common infections in upper respiratory tract, and then you take one organism and talk in detail about that particular organism. So where is microbiology and importance of organism gone? Yes, sir. दूसरी बात, ओके, दूसरी बात, अपर रेस्पिरेटरी ट्रैक्ट 1 घंटे में कवर करना है ये जरूरी नहीं है। दूसरी बात नहीं, तीसरी बात, जब भी हम ऑर्गेनिजम्स या कुछ भी बच्चे को पढ़ाते हैं तो हमारे दिमाग में अगर ऐसा है कि मैं पढ़ाऊंगी तो बच्चा पढ़ेगा, वो दिमाग से निकाल देना चाहिए। यू हैव नो, हाँ, तो इसे पढ़ाने तो फिर पढ़ाने की चिंता हमें इसका मतलब नहीं करनी चाहिए। पढ़ाते नहीं हो, तुमको पढ़ाना ही नहीं है। हमें बच्चों को पढ़ाना ही नहीं है। जब
हमारे पास पढ़ाना नहीं है इसलिए है क्योंकि हमारे पास टाइम ही नहीं है पढ़ाने का। 190 आवर्स में है, 190 आवर्स रहने वाले हमारे पास इतना टाइम ही नहीं है कि हम पढ़ा सकते हैं। तो हमको पढ़ाना नहीं, हम पढ़ा ही नहीं सकते। आपके पास ऐसे 190 आवर्स में कितने पूरा था? जो बड़ा चैप्टर पढ़ा हुआ जाओ तो 20-30% चैप्टर पूरा था, अपना पढ़ाना ना थी।
अगर हमें ये गलत अगर हम ऐसा मानते हैं कि मेरे पढ़ाने से बच्चा पढ़ रहा है, तो वी आर द बिगेस्ट फूल्स ऑन दिस अर्थ, बिकॉज नो वन कैन टीच एनीबॉडी। लेकिन we have to act as facilitators and ensure that the student is moving in the right track. And अगर तुम CBME के अंदर देखोगे तो लेक्चर्स वैसे भी कम है। हमें बच्चों को अपॉर्चुनिटीज देनी है of lots of experiences through certain clinical scenarios, laboratory posting, hospital visits. अगर हम ऐसा सोच लेंगे कि मुझे नहीं एक्सेप्ट करना है इसको, तो भगवान भी आके आपको नहीं देना, करो
बस, और कुछ
नहीं, और कुछ नहीं। मतलब then nobody can do anything. If your doors are shut.
मैडम ने जो बोला that is an end point कि अगर हमको एक्सेप्ट नहीं करना है तो we will not change. हमको एक्सेप्ट करना है तो किस तरह से एक्सेप्ट करना है? that is why I was sure that this all curriculum method is not going to come back.
नहीं आने वाला है।
If we want modification, what kind of the modification we need to do in ourselves and what kind of the modification what we can do in CBME.
What is the flaw in CBME? Are there any flaws?
Of course, every system is going to have certain flaws.
Give it and make it.
Yes, already that, and I have covered in PowerPoint and I will show. मैडम, now just
CBME का सबसे बड़ा फ्लो है कि लोग उसको एक्सेप्ट नहीं कर रहे हैं।
नहीं मैडम, ऐसा नहीं है।
नहीं देखा।
नहीं, ऐसा नहीं है मैडम, एक्सेप्ट करना चाहते हैं पर उसमें जो मोल्डिंग में जो प्रॉब्लम्स है वो थोड़ा कंस्ट्रेंट्स है।
टाइम तो है।
हाँ, उसके वजह से सर આપણે બેઝિકલી
એવના તો વેકેશન કાર્ડ નાખશે તમે શું
અલ્ટિમેટલી આપણે છે ને આ બેની આજુબાજુ ફરીએ છીએ પ્રોબ્લેમ શું છે what the problem we have what the problem we have Any systemic infection, please. Let's just together going towards the conclusion.
Yes.
આપણે બહુ જમા conclusion આવ્યો છે બરાબર મેડમને સાંભળ્યા અને મેડમ બહુ ફર્મ છે અને એનએલસી પણ ફર્મ છે કે નથી ચેન્જ થવાનો એટલે મોડિફિકેશન માટે વિચારીએ
There must be some blending.
મોડિફિકેશન આપણા બાજુ સૈદ્ધાંતિકમાં એ આપણે પછી આવીશું ડિફિકલ્ટીઝ ટીચિંગ ઇન્ફેક્શન ને ટીચ કરવામાં ડિફિકલ્ટીઝ છે કે મલ્ટિપલ એટિયોલોજી સાહેબે કીધું કે 5 ઓર્ગેનિઝમ 5 ભણાવો જશો અને રેસ્પિરેટરીમાં પણ છે એમાંથી એક પાછો સ્કિનમાં પણ આવશે તો એક મેનેજાઇટિસમાં આવે એને ત્યાં ફરી ભણાવશો કે રીતે કોઓર્ડિનેટ કરશો right so that's
Or complete
infections may have multiple etiology at the same time microorganisms have multiple infections એટલે આપણે કયા એપ્રોચ થી જવું ઇન્ફેક્શન થી જવું કે ઓર્ગેનિઝમ થી જવું એ આપણા માટે મેજર પ્રોબ્લેમ છે મેડમ what exactly I want to say right
मैडम सेम
सिस्टमिक इन्फेक्शन से जाता है तो हमको प्रॉब्लम है कि बहुत सारे ऑर्गेनिज्म से जाता है कि बहुत सारे इन्फेक्शन से कैसे जाना है तो हमारा जो उसको जो मैं उसको एड्रेस करूंगा ठीक है मैं उसको एड्रेस करूंगा और मेरे लिए बहुत बड़ा कंसर्न है जो आपने बोला ना वो कोई मेरे लिए बहुत बड़ा कंसर्न है यस मैं उसको एड्रेस करूंगा key aspects to think about the time weightage to study the microorganism versus infectious organism મેન આપણે વિચારવું છે કે ઇન્ફેક્શિયસ ડિઝીઝ ડિટેલમાં જવું છે કે માઇક્રો ઓર્ગેનિઝમ્સ ડિટેલમાં જવું છે એક્ઝેક્ટલી
Yes, yes. That's
એવા ટાઈપમાં ડિટેલમાં જવું સેવા જવું છે
yes.
બંને વાત તો આવવાનું જ છે
Yes. That should be hybrid. There is weightage of microorganism and also syndromic approach of the infectious.
My question is whether a microorganism will studied in local or infection because we have time constraint. વધારે સમય આપવાનો છે we need to focus more. મેડમ ડેફિનેશનની વાત નથી હું તમને છે ને આ મારો કન્સર્ન લઈને આવીશ બરાબર છે we need to focus more infectious disease or common organisms ઇન્ફેક્શન આપણે અત્યારે તો ફોકસ કરવાના જ છે બધાને સર્જન માટે આપવાનો છે but now where we can focus less characteristic of organisms જે characteristic important ન હોય જે આપણે ઓમિટ કરી શકીએ સાહેબ તો બહાર તમે રહ્યા છે સામાન નથી કરતા બરાબર છે આપણે ટેકનોલોજી હું હવે બેઝિકલી હવે આવ્યું આપણે ચેન્જ કરવાનો છે એને ચાન્સ તરીકે લેવો છે જો લેવો હોય તો આપણે વિચારવું પડશે કે આપણે મોડિફાઈ થવું પડશે કે સિસ્ટમને ક્યાંક મોડિફાઈ કરવી પડશે we cannot say blankly no that we are not going to follow that and this is totally match up because we have to think about that and we have to do something definitely so suggestion is man જે ઉપરના પોઈન્ટ છે ને એને નવા સીબીએ માં ઘણા ખરા નથી મગજમાં આવતા એટલે છોકરાઓ મને માઇન્ડમાં જતા રહે છે એટલે કેરેક્ટરિસ્ટિક ઓફ માઇક્રોઓર્ગેનિઝમ્સ છે જેની અંદર આપણે આટલું બધું લેતા હતા એમાંથી એક ઓછું કરી શકીએ હમણાં સાહેબ પણ એગ્રી થયા ક્લાસિફિકેશન છે ઇમ્પોર્ટન્ટ કેરેક્ટરિસ્ટિક છે એવું લઈએ બહુ કલ્ચર બાયોકેમિકલ રિએક્શન્સ કે મોર્ફોલોજીના એક જ બે પોઈન્ટ હોય ધેટ્સ ઓલ્સો ઇનફ બેક્ટેરિયામાં મોર્ફોલોજીકલી તો તમે કોઈ પણ પ્રેઝન્ટેશન જુઓ ને સ્ટેફેલોકોકસની મલ્ટીનેશનલ લેવલની કોઈ પણ પ્રેઝન્ટેશન હોય ને તો બેક્ટેરિયાનું સ્ટાર્ટ થાય તો પહેલી સ્લાઇડની અંદર સ્ટેફેલોકોકસના બધા જ કેરેક્ટરિસ્ટિક આવી જાય એના ક્લાસિફિકેશન આવી જાય મોર્ફોલોજી આવી જાય કલ્ચર આવી જાય બધું જ બાયોકેમિકલ અને પછી સ્ટેફેલોકોકસમાં બધું પેથોજેનિક ચાલુ થાય તમે કોઈ પણ ઇન્ટરનેશનલ સ્ટાન્ડર્ડ પ્રેઝન્ટેશનમાં જોજો એટલે એક સ્લાઇડ જેટલું સ્ટેફેલોકોકસનું પ્રેઝન્ટેશન છોકરાઓ યાદ રાખે ધેટ ઇઝ મોર ધેન ઇનફ more than enough અને આપણે પણ એટલું તો ભણવાનું છે છોકરાઓને એટલું નથી આવડતું what is also issue
એ જરૂરી એટલા માટે છે કારણ કે સર કાલે એ પર્સન ક્લિનિશિયન્સ પણ બનશે, પીડિયાટ્રિશિયન પણ બનશે, સર્જન પણ બનશે અને એ આપણી પાસે જ માગશે માઇક્રોબાયોલોજીસ્ટ પાસે કે વોટ ઇઝ ધ મીનિંગ ઓફ ધેટ જો નહીં ખબર હોય એમને.
બરાબર છે સાહેબ, એટલા માટે એ ભાઈ આ જોયું વાયરસ આવી ગયો. आप बिना लाइसेंस वाले एडोब यूज करे નથી આવતું ભાઈ. હા બસ બસ પત્યું. હવે છે ને હું એક એક્ઝામ્પલ સાથે જોઉં છું સાલ્વિયા ટાઇફી. કેટલાના બ્લડ કલ્ચરમાં ત્યાં બ્લડ કલ્ચરમાં સાલ્વિયા ટાઇફી આવે છે. વાવ સુપર હેન્ડસમ નંબર. હવે બીજું ક્વેશ્ચન, કેટલાની ત્યાં વિલ્સન અને બ્લેરમાં સાલ્વિયા ટાઇફી આવે છે? વિલ્સન બ્લેરમાં નથી આવતા, જરૂર જ નથી. વિલ્સન બ્લેરમાં નથી આવતા તો ચોપડીમાં વિલ્સન બ્લેરનું નામ શું કરવા રાખ્યું છે? સૌથી પહેલા વિલ્સન બ્લેર શું કરવા આવ્યો છે? આપણે પ્રેક્ટિકલમાં પૂછવાના નથી, થિયરીમાંથી પણ કાઢવાની જરૂર છે. બ્લડ કલ્ચર ઇમ્પોર્ટન્ટ છે. બ્લડ કલ્ચરમાં આવે છે. વિલ્સન બ્લેરમાં મેં ક્યારે બનાવ્યું નથી, ક્યારે જોયું નથી આટલી વર્ષની પ્રેક્ટિસમાં, તો વિલ્સન બ્લેર નામ જ ના આવવું જોઈએ. બીજું સાઇડલા એક્સએલડી જીસીઆઈ કોઈ મીડિયાની જરૂર નથી. એગ્રી સર? But how many stool culture you are obtaining for screening of the carrier on Wilson Blair? Very less. એટલે નહીં યાર. સ્કૂલ કલ્ચર એવું છે, ડોક્ટરે વિચાર્યું કે મારે આમાં એ ટાઈપની છે કે નહીં જોયું છે, સ્કૂલ કલ્ચર મોકલે છે, કશું લખતા નથી ને આપણે મેક ન્યુટ્રન પર કલ્ચર કરી એ બોલાય છાપી નાખી દઈએ છે. બરાબર છે. હવે યસ યસ એક્ઝેક્ટલી. હવે આમાં બીજું ક્વેશ્ચન ગઈકાલે પણ ડિસ્કસ થયું હતું. ટાઇફોઇડમાં અમિક એસિડ આપણે ઘણા પાસે તો શું ફિક્સ સર્કલ હોય છે, 8 સર્કલ કે 12 સર્કલ, એમાં અમિક એસિડ આવતું હોય, જેન્ટામેસિન આવતું હોય. મૂકો સાલ્મો ટાઇફીમાં એમાં ઝોન આવે છે? ઝોન આવે છે. તો પછી આપણે કેમ નથી આપતા? એની ટ્રીટમેન્ટ કેમ નથી આપતા? ક્વેશ્ચન કેમ ડિસ્પેરિટી છે? કેમ ડિસ્પેરિટી છે? શું કહે છે ક્લિનિશિયન આપણને? ક્લિનિશિયન આપણને શીખવાડે છે કે આ ઇન્ટ્રાસેલ્યુલર ઓર્ગેનિઝમ છે એટલે એમાંનો ગ્લાયકોસાઇડ નહીં. એ ક્લિનિશિયન આપણને શીખવાડે છે કે આપણને ખબર હોવી જોઈએ. ક્લિનિશિયન આપણને શીખવાડે કે ઇન્ટ્રાસેલ્યુલર ઓર્ગેનિઝમ છે, કયા સેલમાં ગ્રો થાય છે. એ ઇન્ટ્રાસેલ્યુલર ઓર્ગેનિઝમ છે. કમલેશભાઈ તમે અતુલભાઈ સાહેબ પાસે શીખ્યા છો, ભાવિનભાઈ બધા ક્લિનિશિયન મને કહે છે, પીડિયાટ્રિશિયન કહે છે નીચે કોન્ફરન્સ છે એમ કહીશું કે ભાઈ અમિક એસિડ કેમ નથી આપતા? કારણ કે ઇન્ટ્રાસેલ્યુલર ઓર્ગેનિઝમ્સમાં એમાંના ગ્લાયકોસાઇડ કામ ના કરે. તો કયા સેલમાં ગ્રો થાય છે? ટાઈમ ઓછો છે, હોલ ખાલી કરી નાખવો પડશે. તો કોઈ પાસે જવાબ નથી. કયા સેલ્સમાં ગ્રો થઈ શકે? સાલ્મોનેલા કયા સેલમાં ગ્રો થાય છે? Virulence say that matters intracellular growing and that mainly in monocytic macrophages. બ્લડમાં કેટલા મોનોસાઇટ મેક્રોફેજીસ હોય? કેટલા ઓછા હોય? બ્લડમાં એક્સ્ટ્રાસેલ્યુલર સાલ્મોટાઇફી હોય છે. તો એક્સ્ટ્રાસેલ્યુલર અને ફીવર કેમ આવે સાલ્મોટાઇફીમાં? ટાઇફોઇડમાં ફીવર કેમ આવે? બેક્ટેરિયાથી. બેક્ટેરિયા એટલે બ્લડની અંદર બેક્ટેરિયાનો લોડ એક્સ્ટ્રાસેલ્યુલર કિલિંગથી રિડ્યુસ થઈ શકે કે નહીં? અમિક એસિડ તમે બ્લડ સ્ટ્રીમની અંદર બેક્ટેરિયા લોડ રિડ્યુસ કરવા વાપરી શકો કે નહીં? આ બધાનો કોઈની આપણી પાસે આન્સર જ નથી. કારણ કે આપણે એ ડાયરેક્શનમાં વિચારતા જ નથી. અને જ્યારે એની મેનેજમેન્ટ અને ડાયગ્નોસિસની વાત આવે છે, આજે સાલ્મોનેલા ટાઇફી જ્યારે મેડિકલ ગ્રેજ્યુએટ્સ બહાર નીકળે છે ત્યારે પૂછો ને તમે કોઈને પણ ક્વેશ્ચન, અત્યારે પણ એમબીબીએસ આવે અને પૂછો કે સાલ્મોનેલા ટાઇફી મેડિકલ ડાયગ્નોસિસ કરે વિદાઉટ ટેસ્ટ વિલ્સન બ્લડ કલ્ચર. બ્લડ કલ્ચર પણ કહેશે, બ્લડ કલ્ચર કહેશે, તો બ્લડ કલ્ચરમાં શું કરીશું? ત્યારે માથું ખંજવાળશે. પહેલા પણ ખંજવાળતો હતો. કારણ કે બ્લડ કલ્ચરમાં 5 ml 2 ml બ્લડ અગર કે બ્લડ કલ્ચર આવે કન્ફ્યુઝન થતા હતા. પણ વિલ્સન બ્લોટના મગજમાં હશે જ. એ આપણે આપણું કાઢી નાખવું છે. જો આના મોટા ભાગનો કચરો કાઢી શકીશું એ આપણે વિચારવાનું છે. અને એ પીજીસ તમારે વિચારવાનું છે. આ મેડમ ફોર એક્ઝામ્પલ મેડમ છે, સોનિયા મેડમ છે કે સુમનસિંહ મેડમ છે, એ પોતાના રીતે પોતાના કન્સર્નથી કામ કરે છે. બટ ઇટ્સ નોટ ગોઈંગ ટુ એફેક્ટ ધેર કેરિયર એટ ઓલ. એમને માઇક્રોબાયોલોજી સબ્જેક્ટનું કન્સર્ન છે, પેલા મેડમની ઇન્ફેક્શન ડિઝીઝના સબ્જેક્ટનો કન્સર્ન છે, એમનો કન્સર્ન છે, બટ ઇટ્સ નોટ ગોઈંગ ટુ એફેક્ટ ધેર કેરિયર એટ ઓલ, બટ ડેફિનેટલી ઇટ વિલ એફેક્ટ યોર કેરિયર. Whenever you are going to come outside at the clinical microbiologist, you will face the problem what the world is facing. Yesterday, તમે જે સાંભળ્યા બધા લેક્ચર, તો ગઈકાલે ફ્રેન્ડે કીધું કે હજુ ખાલી 10% જ ડોક્ટરો કલ્ચર લગે છે, 90% હજુ કલ્ચર આપવાનું શરૂ નથી કર્યું. એમની પાસે કરાવવાનું છે તો એમની પાસે સારી રીતે કરાવવાનું છે. એ કોણ કરશે? આપણા જે મેડિકલ ગ્રેજ્યુએટ બહાર નીકળી જે આવશે, અત્યારે જે પીજીસ કરે છે, જે તમારી જોડે ઇન્ટરેક્ટ કરે છે, એ બહાર નીકળીને આવશે ને ત્યારે એ લોકો કરશે. અને જો એમની પાસે પ્રોપર કરાવવું હોય તો આપણે ટ્રેડિશનલ વે તો નહીં જ ચાલે, ભલે આ સીબીએમઈ ના ચાલતું હોય, પણ ટ્રેડિશનલ તો નહીં જ ચાલે. દેટ ઇઝ વેરી મચ સિક્યોર. આ એકદમ શ્યોર છે, કારણ કે ટ્રેડિશનલ વેમાં કોઈ પ્રોપર શીખ્યું નથી. We have to move towards the new some methodology, some technique. We will work on that. Need to change. આપણે આ ચેન્જીસ ની અંદર આવા લાઈફ શકીએ કે ઇન્ફેક્શિયસ ઓર્ગેનિઝમ્સ ને પણ ફોકસ કરીએ અને ઇન્ફેક્શનના કેસીસના પણ ફોકસ કરીએ. ઇન્ફેક્શન ઓર્ગેનિઝમ સેન્ટ્રિક ના રાખીએ, ઇન્ફેક્શનના સેન્ટ્રિક ના રાખીએ, પણ બંનેને એક ડિવાઇડ કરીને ફોકસ કરીએ. મેડમ હું તમારા પાસે પછી લઈશ, ટાઈમ હશે તો, સંજય કહેશે તો. પણ આ મેડમ આ બેમાં પણ વિચારી જુઓ, જો આમાં સીબીએમઈમાં થઈ શકે તો. અત્યારનો પ્રોબ્લેમ એ છે હાઉ ધ માઇક્રોબાયોલોજી સબ્જેક્ટ માઇક્રો ઓબ્ઝર્વ બાય ધ મેડિકલ્સ. હવે સોનિયા મેડમ તમારો જવાબ. માઇક્રોબાયોલોજીસ્ટ આર નોન મેડિકલ્સ. અત્યારે ક્લિનિશિયન એવું વિચારે છે. કેમ? કારણ કે આપણને માઇક્રોબાયોલોજી શીખવાડે છે. હું યુજીના મારા થોડા યુજીસના સ્ટુડન્ટ્સ અહીંયા આવી ગયા, પહેલા જ લેક્ચરમાં ક્વેશ્ચન પૂછ્યું છું કે વોટ ઇઝ ધ ડિફરન્સ ઇન માઇક્રોબાયોલોજી ઇન અધર સબ્જેક્ટ્સ. કોઈ એકાદ હોશિયાર છોકરાએ આન્સર પણ આપ્યો હતો કે માઇક્રોબાયોલોજીની અંદર હ્યુમન સિવાય બીજું શીખવાડવામાં આવે છે, બાકી બધા સબ્જેક્ટમાં હ્યુમનનું શીખવાડવામાં આવે છે. એનાટોમી, ફિઝિયોલોજી, બાયોકેમિસ્ટ્રી, ફાર્મેકોલોજીની અંદર પણ ડ્રગ બોડીમાં ક્યાં એફેક્ટ કરે છે, પેથોલોજી, બધા એમાં હ્યુમન શીખવાડવામાં આવે છે. માઇક્રોબાયોલોજીમાં આ 2011 બેચના એકાદ બે છોકરાઓ છે. બરાબર, સૂરજે મને જવાબ આપ્યો હતો કે સાહેબ માઇક્રોબાયોલોજીની અંદર આપણે હ્યુમન સિવાયનું શીખવાડીએ છીએ અને બીજા બધા સબ્જેક્ટમાં હ્યુમન શીખવાડે છે. ત્યાંથી જ આપણા માટે એમના મગજમાં ગ્રંથિ બંધાઈ જાય છે કે આ માઇક્રોબાયોલોજીસ્ટ એ ટોટલી ફ્રીલી નોન ક્લિનિકલ, નોન ડॉक्टर ब्रांच છે.
सर वी आर रिस्पॉन्सिबल फॉर दिस ऑल्सो, क्योंकि हमने खुद को ही अपने आप को एक वो हीन भावना में रख रखा है कि वी आर माइक्रोबायोलॉजिस्ट, इसलिए हम क्लिनिशियंस की तरफ भागते हैं. यदि मुझे पसंद है मेरा सब्जेक्ट, मैं उसको वट से पढ़ाऊंगी बिल्कुल दिल से, तो वो भी उसको लाइक.
मैडम क्लिनिशियन की तरफ नहीं भागना है.
आई एम टीचिंग पैथोजेंस.
मैडम आपका कंसर्न बहुत सही है, आपका कंसर्न बहुत सही है कि बच्चे अभी वेरी मच दे आर कंफ्यूज बिकॉज वी हैव लेफ्ट द ट्रेडिशनल वे. એટલે માઇક્રોબાયોલોજીમાં આપણે કંઈક ખોવાઈ ગયા છીએ. પણ આ પણ ફેક્ટ છે કે આપણને ક્લિનિશિયન આવી રીતે જુએ છે, પ્રી ક્લિનિકલ, નોન ક્લિનિકલ. એ લોકો ખાલી માઇક્રો કરે, ભણાવે અને બહુ તો કલ્ચર કરે.
कोविड में भी हमें नेशनल टीवी पे पैथोलॉजिस्ट ही बोला गया था.
उनको पता ही नहीं है. और वो मैं अजय जो બધા કીધું ને કે પીસીઆર ને બાયો, હમણાં આપણે કોણ જોડે વાત થતી હતી, આ મિત્રેશ જોડે વાત થતી હતી. નીચે તમે જુઓ સ્ટોલમાં ટેકનોલોજી આવી ગઈ છે, નાના નાના મશીનથી કેટલું બધું થાય છે. એ બધું હવે આપણા હાથમાં નહીં રહે. જેના પાસે પૈસા હશે એના હાથમાં રહેશે, પેથોલોજીસ્ટ કરશે. જેની પાસે સીબીસી જશે એની પાસે એ બધા જશે. એટલે આપણા હાથમાં નથી. એટલે ફોરગેટ અબાઉટ ધ પીસીઆર એન્ડ ઓલ ધીસ ટેકનોલોજી, બાયો એર આ બધું ભૂલી જાઓ. એ તમારું હાથમાં નથી રહેવાનું. આપણા હાથમાં ક્લિનિકલ માઇક્રોબાયોલોજી, ઇન્ફેક્શિયસ ડિઝીઝ. બોલો બોલો સાહેબ.
આપણે છીએ
નહીં. Who is responsible? સાહેબ કહું તમને, હજુ પણ આપણે મેથડ રિસ્પોન્સિબલ છે. આપણે મેથડ રિસ્પોન્સિબલ છે બીકોઝ આપણે સાહેબ અત્યારે આ જો કમલેશ ઉભો થઈ જતો રહ્યો. અત્યારે અમદાવાદ, સુરતમાં મોટી મોટી લેબોરેટરીમાં અને હોસ્પિટલમાં, કોર્પોરેટ હોસ્પિટલમાં માઇક્રોબાયોલોજી જગ્યા થોડા સમયથી ખાલી જ રહે છે, ઘણા સમય સુધી ખાલી રહે છે. કારણ કે એમને ક્લિનિકલ માઇક્રોબાયોલોજી જોઈએ છે. મેં કહ્યું હું પ્રોવાઈડ કરું તો તેના અમારે એક્સપિરિયન્સ જોઈએ છે. વાય એક્સપિરિયન્સ્ડ? because they know કે ભાઈ પીજીસ ની અંદર કયા રેસ્ટ્રિક્શન છે. એ 2 મિનિટમાં કીધું યાર ફટાફટ. ચલો ઓકે સો ફાઇનલી આપણે આટલું જોઈએ છે મેં કટ શોર્ટ કરી નાખ્યું છે બરાબર કે આપણે ડાયગ્નોસ્ટિક ઇન્ફેક્શનમાં આમનો મેઇન રોલ છે બેઝ પર્સન ટુ ગાઈડ એન્ટીબાયોટિક થેરાપી એવું આપણી રીતે વિચારે કી પર્સન ડિસાઇડિંગ એન્ટીબાયોટિક પોલિસી ફોર હોસ્પિટલ અને એક
હમણાં જે પેલો કોઈ કહાવ પર બહુ સરસ કર્યું હતું અગર એવરીબડી લેવી ને તો કોઈ આપણો જે વોટ્સઅપનું જે આપણું ટાઈમ ગ્રુપ છે ને એમાં એક ટાઈમ ઝોન રાખીએ મેબી 8 to 9 or 7 to 8 ને વોટ્સઅપ પર જ ઇશ્યુઝ લખો અને બધા પોતાના આન્સર લગાવે
ના થાય ના ના બરાબર છે પણ આ એક કદાચ અહીંયા થવું જરૂરી હતું હું સોનિયા મેડમને આન્સર આપણને ભૂલી ગયો કે મેડમ એટલા માટે આપણે માઇક્રોબાયોલોજી સબ્જેક્ટની જગ્યાએ છે ને બને તો આપણે નામ ચેન્જ કરીએ માઇક્રોબાયોલોજી સબ્જેક્ટની જગ્યાએ ઇન્ફેક્શન રાખીએ પણ માઇક્રોસ્ટિક જોડે રહીશું ને તો લોકો બહાર આપણને હજુ આ જ રીતે ઇવેલ્યુએટ કરશે क्लिनिकल माइक्रोबायोलॉजी तरीके करी
So I would just like to add कि इसको ध्यान में रखते हुए पोस्ट ग्रेजुएट्स का करिकुलम भी पूरा के पूरा रिवाइज कर दिया है and that has now lots of clinical components incorporated it into it. सर टिश्यू कल्चर्स के अलावा और बहुत सारी दूसरी चीजें भी होंगी कुछ चीजें नहीं निकली लेट अस सी व्हाट इज सो लेट अस सी सर हमको ये सोचना चाहिए कि इंडिविजुअल लेवल पे और इंस्टीट्यूशनल लेवल पे हमारे लिए जो पॉसिबल है वो हम करेंगे बहुत सारी चीजें ऐसी होंगी जो हमारे लिए नहीं पॉसिबल होगा उसके लिए हम अपने आप को ट्रेन करेंगे सर बहुत सारे नेगेटिव पॉइंट्स हो सकते हैं वी आर नॉट गोइंग टू गिव आंसर सर आई डोंट नो कि किसने डाला है पर मैं जस्ट बता रही हूँ
what we can do because they keep that open एक महीना માટે ઓપન કરેલી એમાંથી જો 10-15 જણા ખાલી સજેશન મોકલે ભાઈ આ કાઢી નાખો તો ના નીકળે એટલે જો મેક્સિમમ લોકો એપ્રોચ કરે અને સજેશન્સ આપે કે આ સિસ્ટમમાં ખોટું છે એક મહિના માટે ડ્રાફ્ટ મૂકે છે તો તમે કમેન્ટ લખી કરો વધારે લોકો વેગડ સાહેબ છે કે એવા 5-6 જણ જો કદાચ એક્ટિવ થઈને મોકલે અને સિંગલ ફોર્મ મૂકે 5-6 જણ મોકલે
टॉपिक है सर
હવે હું જો એક છેલ્લું કન્ક્લુઝન કરી નાખું કેટલા સંજય મને કાઢી મૂકશે ઉચકી લઈ જશે બહાર કે આપણે કટ શોર્ટ આ મને ગઈકાલે જ વોટ્સએપમાં મળે છે ધ ઇલિટરેટ ઓફ ધ 21st century this is for 21st century will not be those who cannot read and write but those who cannot learn unlearn and relearn so we have to take the opportunity to change as an opportunity though it is a challenge but we have to work upon that આ તો ખાલી બિગિનિંગ છે હજુ આમાં ઘણું જ ડિસ્કશન થઈ શકશે અને ડેફિનેટલી સુમન મેડમ થોડુંક મોડિફિકેશન તો કરવું જ પડશે થેન્ક યુ
हाँ it is not in my hand but definitely I will request कि जिस को भी जो भी problems हैं write them specifically put तो सर हम कोशिश करते रह सकते हैं So let us just try सर हम क्या कर सकते हैं हम सिर्फ ट्राई कर सकते हैं और अल्टीमेटली तो when something is inevitable it is better to lie down and enjoy so just enjoy it do whatever is possible maximum so just make your efforts हम हमारे हाथ में कुछ नहीं है चलो थैंक यू सो मच थैंक यू
मैडम बहुत सारा बात बराबर चलना संग्रह साहब जो तमाम सभी लोग कार्य कर रहे हैं को मेरे वाले के नाम करना स्टार्ट वाला कर दिया
Thank you so much. I hope everyone gets their solution very fast. I would like Urvas sir to felicitate our panelists. Please, sir, do the honors.
All are requested to wait for a few minutes, please. All are requested, please don't go away.
Please be seated. We have to declare the result of the quiz. I request all of you to be seated for at least 5 minutes more. 20 minutes more, sorry. We have to declare the results of quiz, paper and poster. I request Dr. Ninesh Vadasma sir to felicitate Dr. Oves sir.
I request Dr. Bharti ma'am to give the prize to the quiz winners. Please, ma'am. Dr. Nidhi Patel. Last three digits of mobile number are 065. Dr. Ritapa Ghosh 009. Dr. Meera Bhuth 830. Dr. Sangeeta Patel 579. Dr. Devyani 502. જે અવેલેબલ છે આવી જાઓ.
Okay. Start. Quickly, we will start with the quick. Quiet, please. Okay. Start with. Start with paper oral presentations. We divided the total participants, 33 participants, into two groups, and each group has a two ranking, first and second. Okay. So group 1 second rank, then first rank. Manish bhai.
Group 2, Group 1, second rank is Dr. Sunny Chauhan. And Group 1, first number is Dr. Gaurav Chotalia.
For the group 2, the second prize.
Group 2 second prize goes to Dr. Utsav Solanki from PDU Rajkot. And the first prize goes to Dr. Akash Shah from NHL Medical College.
First raise.
Now poster presentation. Second prize goes to Dr. Dhwani Patel, BJ Medical College, and Dr. Mittal Ansari, GMC Bhavnagar. There are 2 second prizes. And first from Bhavnagar, anyone from Bhavnagar?
मैडम आपकी
And first prize goes to Dr. Renuka Sadhya, BJ Medical College. सर ने बोला ही हम नीचे पहुंचे सेकंड
संजय
બે મિનિટમાં કોઈ ભાષણબાજી કરવા માંગતો નથી પણ 2 દિવસથી જે 3 જણા આપણી સામે ને સામે બેઠા છે અલગ અલગ કેરેક્ટરમાં આવીને આપણને એન્ટરટેઇન કરતા કરતા આજે આપણે આખો પ્રોગ્રામ કન્ડક્ટ કર્યો છે જો આપણે એમને ફેલિસિટેટ નહીં કરીએ તો પ્રોગ્રામ અધૂરો જ રહેશે તો પ્લીઝ give big round of applause to all of our three heroes. Hardik, Rachna, Palak, please come. May I request Bigger sir, please.
Thank you, madam. Sir, Abad.
Thank you.
Two more little ball. They are moving here and there in the stage with the memento, and we have to appreciate their patience. They are just standing behind everything. We cannot see them, and they are very patient and smart girls. Please come. Please come. Both of you. Please come.
સવારે અમારો નિયમ છે રવિવારે પણ રિપોર્ટિંગ કરવાનું છે અમે અહીંયા પહોંચી જવાનું સવારે 7:30 વાગે જીસીએસમાં રિપોર્ટિંગ કરીને આવ્યા છે That is good change. Kanu sir.
Kanu bhai, please.
Nita madam. Hello. Kanu sir and Nita madam soliciting.
And yesterday, one more girl was there, Tanvi. Where is she?
Sigma Ben, please.
હા હા લાઈટ બંધ કરાવી દઈએ, આપણે બંધ જ કરાવી દઈએ, બધું બંધ કરાવી દઈએ, હવે કોઈને કશું આપવાનું નથી. So it was fun, 1.5 day. We have enjoyed a lot. Thank you everyone. Thank you for coming here, all the delegates, all the speakers, all the chairpersons. Thank you, big thank you to make this event a grand success. And let's not forget the scientific committee. They have taken a big headache to select the abstracts, to scrutinize them, and to make it possible with all our judges, because judges also have played a big role to decide. Yesterday, I think they were talking about something happening, that to whom to give first prize, second prize, and to whom select. They were also confused. So it was great research over there. 69 participants. Thank you all. Thank you judges.
બધા ફટાફટ છે ને સાયન્ટિફિક વાળા પણ ઉપર આવી જાઓ અને આપણે ઓર્ગેનાઇઝિંગ વાળા પણ ઉપર આવી જાઓ. એક છેલ્લે એક ગ્રુપ ફોટો મોટો પાડી દેવો છે અને બધા સિનિયર્સ સ્પોન્સર્સ બધા સાહેબો વેગન સાહેબ, કમલ સાહેબ, સુદીપ સાહેબ, મેઘાનારાયણ, સેનાભાઈ, બધા નામ ભેગા બધા ઉપર આવી જાઓ.
चलो चलो चलो
Hello. And thank you to our event management team also. Mr. Hussain Sona on the stand. Please clap for them. Please clap for our event management team. Where is Roshan? Asad? Asad? So they have done a very good job, tremendous headache. They have done. And the most importantly are the sponsors. A big thank you to all our sponsors, because of them we have done this program.
ના બધા પડાવવાનો ફોટો, આપણે બધા ફોટા જ છે.